하고 걔가 잘라. 돌리면 이렇게 하고 내가 맞지? 살짝 돌리면 나.
걸고 출발 발사. 오, 이 소리 뭐야?
Of cancer as the first of the afternoon sessions. I'd like to welcome our two moderators for the session. Please welcome them with a big applause. 좌장 두 분 앞으로 모시겠습니다. 큰 박수 부탁드립니다.
안녕하세요. Good afternoon, everyone. I'm in the home. I'm actually an exercise scientist too. Thank you for joining us in session 3, exercise as treatment. We are delighted and honored to have two speakers in this session. Dr. Ji-Min, she is a co-chair. and also one of my best colleagues really introduce the first.
Thank you, Dr. Kung. Hello, I'm Ji Min from National Cancer Institute. It is with great honor that I introduce our first speaker, Dr. Jessica Good. She is leading researcher in exercise and cardiovascular outcomes. She graduated from University of Alberta and received her master's and doctorate degrees in exercise cardiology from University of British Columbia. She then gained a much research experience in space-flight exercise physiology at the Johnson Space Center, NASA. She currently works at the Memorial Sloan Cancer Center and read various studies on cancer, exercise, cardiovascular outcomes. The topic of today's presentation is optimizing exercise training to offset cancer treatment-related toxicity. Please welcome Dr. Jessica Good.
Thanks, Justin, for the invitation to speak at the conference today. I'm excited to share some of our work looking at optimizing exercise training to offset cancer therapy-related toxicities. I have no disclosures.
When we think about multi-system
toxicity, this really stems from
patients
treatment
are exposed
that
to.
patients are exposed to.
Diagnosis,
Patients may have a pre-existing risk factor like smoking or hypertension or older age. They are then exposed to the direct hits of cancer therapy, chemotherapy, radiation, or surgery, and also indirect hits. So these are factors secondary to chemotherapy or surgery where patients may not feel as well, so they don't exercise as much, or they may change their diet and gain weight or lose weight. So collectively, these multiple hits impact basically every single system in the human body. But what is commonly used for cancer toxicity management, at least in the United States, is fairly basic. So how these toxicities are evaluated are typically done at one point at diagnosis, and this may include a subjective evaluation of performance status of a functional capacity, or it could include a simple measure of echocardiogram to look at heart function, or a pulmonary function test to look at lung function. And how these toxicities are typically managed is very pharmacologically driven. So pre-therapy, if a patient is perceived to be at increased risk of toxicity, an oncologist may decrease the dose of the drug that is given. Similarly, during therapy, there may be a decrease in dose, or there may be some pharmacological adjuncts. And this is also the case in the post-treatment setting, where it's very pharmacologically driven. And what our group is interested in looking at is changing that paradigm a little bit and looking at how can we broaden the phenotyping of multi-system toxicity to look beyond those simple metrics. So looking at everything from the behavior down to some molecular changes that may occur or some pre-existing factors that may contribute to that multi-system toxicity. And in terms of management, we know that pharmacological-driven approaches are necessary, but exercise training may be a very important adjunct to help offset some of those toxicities. So looking at exercise, not just at a single time point, but starting at the point of diagnosis and that pre-therapy, so some prehabilitation. During therapy, we call that habilitation. And in that post-treatment setting, rehabilitation to bring patients back up to that baseline level. So for the talk today, I'll go through some of the approaches that our group has used in terms of phenotyping and an individualized exercise prescription. And I won't go into all of the different phenotyping tools that we've used, and I'll focus on one tool that our group and Leah's used for over 20 years, and that's evaluation of cardiorespiratory fitness. And it's a great tool because it looks at multiple systems at one time. And I mentioned our group has been interested in this metric, exercise testing, to evaluate cardiorespiratory fitness for a long time, but we had a postdoctoral fellow from Norway work with us, and she recently completed a systematic review looking at all the different exercise tests that have been used to evaluate cardiorespiratory fitness. So in that systematic review, she found that almost 500 studies had evaluated cardiorespiratory fitness in patients with cancer, almost 70,000 patients. And the majority of these tests were two tests. It was either a 6-minute walk test or a cardiopulmonary exercise test. And each of these tests have different pros and cons. The 6-minute walk test is great because it has widespread availability. You can do this in any setting where you have a hallway and a watch to time people. The limitation of this test is that there is a ceiling effect. So for patients that have good performance status or have early stage disease, they have limited ability to discriminate between those high functioning patients. And that's where a cardiopulmonary exercise test is the gold standard tool. You can directly measure peak oxygen consumption. The downside of it is that you do need specialized equipment and personnel, but this is the test that our group uses to evaluate cardiorespiratory fitness in all of our trials. Now, we also looked at the association between cardiorespiratory fitness and all-cause mortality. And there was a limited number of studies that evaluated all-cause mortality, but there were 15 studies and just over 6,000 patients. And we found that compared to a low cardiorespiratory fitness, those with high cardiorespiratory fitness had almost a 50% reduced risk of all-cause mortality. So this is really highlighting the importance of this metric, and we really need interventions that can improve cardiorespiratory fitness. And the one and only intervention that can improve that is exercise training. There's not a single drug that can be used to augment cardiorespiratory fitness. So when we look at the trajectory of cardiorespiratory fitness across the cancer continuum, this has been work done over the past 20 or so years. We know that with healthy aging, we typically lose about 10% per decade. And what we see with patients with cancer is there's an accelerated decline in cardiorespiratory fitness. So pre-treatment, patients may have almost a 20% lower cardiorespiratory fitness compared to age-matched controls. During treatment, that declines anywhere from 10 up to 20%, depending on the treatment regimen. And in the post-treatment setting, there may be some recovery, but in cross-sectional studies, cardiorespiratory fitness is about 30% lower compared to age and sex-matched controls. And this accelerated decline places patients at increased risk of events, and particularly cardiovascular disease events. So in observational studies, we can see that patients have about a 20 to 50% increased risk of cardiovascular disease events compared to individuals that have not been treated with cancer therapy. So again, this is why we're so interested in exercise training, because we need a tool that can augment cardiorespiratory fitness. So looking at some of the evidence over the past 10 years, exercise oncology is a fairly new field, but there's burgeoning evidence that exercise is really important. So looking first at observational evidence, this was a study that looked at post-therapy exercise and cardiovascular disease events in women that were previously treated for breast cancer. And here we can see that those that reported the highest levels of exercise had almost a 30% reduced risk of a cardiovascular disease event. But there was evidence of benefit in the third quartile, which showed that anywhere from 90 up to 200 minutes was associated with a benefit. We can see this in other settings as well. This study, we looked at post-therapy exercise in adult survivors of childhood cancer. And after 10 years of follow-up, we found that those that were reporting just about 30 minutes of exercise per week had about a 20% reduced risk of all-cause mortality. So this observational data is very encouraging, but there are limitations. We know that a lot of these studies use self-reported exercise data, which has limitations, and it's difficult to assess those direct exercise-induced effects. So that's why we're very interested in randomized trials. So to do an initial look at whether exercise training was associated with benefits in cardiorespiratory fitness, we did a meta-analysis looking at randomized trials that included an exercise group and a non-exercise control group. And we found that compared to a non-exercise control group, those that were randomized to exercise had an improvement of about 2 milliliters per kilogram per minute. So that's a pretty substantial improvement. However, you can see there's a lot of heterogeneity across all of these studies, with some benefits, with some studies showing a lot of benefit and others showing minimal benefit. The other interesting aspect to note was that the dose tested was fairly low. So it was ranged anywhere from 100 up to 150 minutes. So this is not a high dose of exercise that was tested. So on the basis of those observational studies and those randomized trials, the current guidelines recommend anywhere from 90 up to 300 minutes per week of exercise to improve the physiological and patient-reported outcomes. Now, we think there are some limitations with these current guidelines, and that is that it's a one-size-fits-all approach. So individuals in these trials will typically do that standard dose anywhere from 100 up to 150 minutes, which likely has benefits for a subgroup of patients, but for the majority of patients, they may not respond to that particular dose. So our group has been really interested in delving into some of those questions and looking at different approaches to exercise training. And some of the key questions that we've been interested in is, if you start exercise training before you start therapy, can you augment, preserve, and improve outcomes? If you exercise during therapy, can you mitigate that decline or maybe improve treatment tolerability? If you start exercising after treatment, can you reverse the declines that you observe during therapy? And most importantly, across all of these settings, is what is the optimal exercise prescription? So that's what our group has been focused on for the past 10 or so years, is how can we optimize exercise training for each individual patient? And we've done a couple of trials over the past few years delving into that question. And one of the first questions we were interested in was, what is the optimal exercise sequence? The typical program that is used in the majority of trials that we looked at in the exercise training meta-analysis used a linear moderate intensity approach. So that's illustrated in this graph, where every single time a patient comes in, they exercise for the same duration, typically about 30 minutes at the same intensity, typically about 70%. So moderate intensity and moderate volume. And what we were interested in was testing a nonlinear approach. This includes high intensity interval training and some longer, lower intensity duration days, which is exactly how athletes train. So this had never been tested in patients with cancer before. So to test this, we conducted a trial where we randomized 174 breast cancer survivors to about 150 minutes of exercise for 16 weeks. And they were randomized to a stretching control group, a linear exercise group, so that was the same moderate intensity every single time, or the nonlinear exercise program that included some higher intensity and lower intensity exercise. Our primary endpoint was cardiorespiratory fitness. And what we found was that, as we hypothesized, the nonlinear exercise arm was associated with the greatest benefits in VO2 peak or cardiorespiratory fitness. And it was interesting to also note that adherence was higher in the nonlinear group. So there was some patients that mentioned it was much more enjoyable to do a different exercise session, some higher intensity and some lower intensity days than the same thing every single time. Another question that we often get asked is, what is the optimal exercise modality? We know that aerobic exercise is great because it targets the heart and the blood vessels and the cardiovascular system, but resistance exercise could also be another important modality because it targets muscle. And a lot of patients have low muscle mass, so perhaps improving muscle mass could be important. But the best of both worlds might actually be the combination of the two. So a combined aerobic and resistance program that can target the cardiovascular system as well as increase muscle mass. To test this, we randomized 90 lung cancer survivors to 16 weeks of either stretching control, aerobic alone, resistance exercise alone, or that combined aerobic and resistance program. And a little bit to our surprise, we actually found that the aerobic training alone program was selected as the best modality to move forward. And this was apparent for a couple of different reasons. The improvement in fitness was similar between the aerobic alone group and the combined program, but adherence was much higher in the aerobic alone group. And that was primarily due to the fact that patients had a lot of trouble adhering to the resistance training program. So given the fact that the aerobic training program required less time and had a higher adherence, we selected and now use aerobic training as our primary modality in our trials moving forward. The third question that we asked was, what is the optimal time to initiate exercise training? And there are a couple different thoughts on to when patients should initiate if they are initially inactive. So one thought is that concurrent exercise, so exercise during treatment, would be the best modality because it would offset therapy-induced declines. Another thought was that sequential exercise might be the best because it can allow patients to rest while they are receiving treatment, but then initiate exercise training right after they've received or completed therapy and could then really get into the exercise program. And the final thought was, well, what about continuous exercise? So if you could exercise throughout your cancer therapy and then continue it post-therapy, could you improve your fitness or cardiorespiratory fitness to a higher level than baseline? So to test this, we randomized 158 breast cancer patients that were initiating chemotherapy, and they were randomized to about 32 weeks of about 90 minutes of either usual care control, which just included some physical activity advice, concurrent exercise, so exercise only during therapy, sequential exercise, nothing during therapy and initiating right after the completion of therapy, or that continuous program where you exercise during and after therapy. And what we found was that in terms of our primary endpoint, which was VO2 peak, there was a greater improvement with the continuous training arm compared to the usual care control or that physical activity advice. So this really suggests that patients should initiate exercise treatment early during therapy and then continue it post-treatment if possible. So those are all some of the trials that we recently finished, and we've gleaned a lot of great evidence on what we're now proposing as the optimal modality, sequence, and timing of exercise training. But as we were looking a little bit deeper in the data, we also realized that there were some notes of caution, and that involves looking at the heterogeneity in exercise training response. So these are waterfall plots from our 2 trials in breast cancer. On the left, we have our breast cancer during therapy, and on the right is breast cancer after therapy. You can see there's incredible variability in the change in VO2 peak for each individual patient, which is represented by a bar. And I've highlighted the 2 arms that we selected as moving forward to further test that despite really great adherence in the continuous arm and in the nonlinear arm, the response rate or improvement in VO2 peak above a clinically relevant threshold was very low. It was only about 20%. So that really highlighted to us that we need to do a better job with our exercise training program, and what different ways can we try and improve the program so that we can get more patients to have an improvement in VO2 peak or cardiorespiratory fitness. So we've got a couple of ongoing trials that are evaluating higher exercise volume. The thought is that perhaps the dose of exercise that we've tested, whether 90 minutes or 150 minutes, may not be enough to offset that chemotherapy hit that patients get. So on the left is our trial that is currently ongoing during therapy, where patients are randomized to an adaptive exercise arm where they can, if they tolerate the exercise, they can go up to 300 minutes per week of exercise, or the standard arm, which is 90 minutes per week of exercise. There's 2 phases to this trial, where if they have a response after 32 weeks, they transition into unsupervised aerobic training. And if they don't have that clinically relevant threshold of change in fitness, they transition into the adaptive aerobic training arm, and all of this exercise is supervised by exercise physiologists. In the post-treatment setting, we're looking at testing higher doses, so moving from 150 up to 300 minutes per week of exercise, or increasing the length of the training from 16 weeks to 32 weeks. Will that help improve response rate? The primary endpoint in both of these trials is the VO2 peak response rate, so the proportion of patients that experience that relevant change in fitness. So all of the trials to date have focused on that physiological endpoint of cardiorespiratory fitness, but another key challenge is, could exercise potentially help patients tolerate their chemotherapy better? So a systematic review that came out several years ago identified that there was a major gap, that there have been no exercise trials that included treatment tolerability as a primary endpoint. And of the 9 or so that had evaluated treatment tolerability, most of them were done in breast cancer settings where treatment tolerability is generally above 90%. So it's not a huge issue. So to try and address some of those challenges, we have a trial going on right now where we're looking at the dose response of aerobic training on treatment tolerability in patients initiating chemotherapy for colorectal cancer. And the dose response, again, we're trying to identify if there's an optimal dose. So patients are randomized to 90 minutes, 150, or 300 minutes a week of exercise for the duration of their chemotherapy. And we also have some secondary endpoints that we're looking at, like post-surgical events, length of stay, length of hospital stay, and some tumor-related outcomes as well. So that was a quick overview of the trials that we've had going on, looking at multi-system toxicity. And a quick summary is that we know that cancer therapy is associated with multi-system toxicities. We typically use cardiorespiratory fitness to evaluate those toxicities. Exercise training is a great tool to improve cardiorespiratory fitness at the group level. But as we're seeing, it looks like we need to start incorporating some more personalized exercise approaches, and different approaches and different doses may be needed to help optimize individual patient responses. So with that, I'd like to thank Justin again for the invitation, as well as our team at Memorial Sloan Kettering, and Lee Jones, who is our fearless leader. So thank you very much.
I'd like to ask a question about the modality of exercise. In one of your study with a lung cancer patient, the adherence rate for resistance exercise was really low. So do you think this is just for lung cancer patient?
Yeah, that's a great question. The primary trial that we did was in lung cancer, and those patients had a pretty low VO2 peak, and some of them were pretty frail. So we did hypothesize that the resistance training would help augment VO2 peak more. So I think we were surprised that that combined program, or that the patients had difficulties adhering to the resistance training program. I think in other settings, we may see differences. I know other groups have done resistance training in prostate cancer and have had a lot of successes. And I think it also depends on what the endpoint you're looking at. So our primary endpoint has been fitness. And I know if you look at improving muscle size or muscle mass, for example, resistance training is the most important tool that you could have to improve muscle mass. So I think it really depends on what your endpoint is, and that helps drive your exercise modality.
But then my follow-up question on that is what type of resistance training program did you prescribe to your patient?
It was we included upper body, lower body. It was all supervised. So it was a very intensive program, and it was also a non-linear resistance training program. So patients would do some higher reps and some lower loads with higher reps, and vice versa. So it included a lot of the principles that we use with aerobic training and incorporated it into resistance training as well.
We see there's a lot of variability of patient's condition. So how did you put that into account when you prescribe exercise program for them?
Yeah, that's a great question. And I didn't have time to get into it, but we have a very rigorous approach to exercise training where every single session is supervised. And it's very much like a chemotherapy drug regimen where if a patient is feeling tired, we could resequence. So we use very similar terms for exercise training. So like I said, if a patient is feeling tired, we could do a dose reduction or a dose resequencing. So if they were scheduled for a zone 5-day, high intensity day, but they come in and they say, I'm so tired, I can't do that high intensity day, our exercise physiologists will work with the patient and say, okay, how about we try a zone 1 today, and then we'll try the zone 5 on Friday. So there's a lot of back and forth and communication with the exercise physiologists, and we capture all of that data. And that's how we have an exercise relative dose intensity that's very similar to a chemotherapy relative dose intensity. And so we know what the prescribed amount of exercise is and what the received amount of exercise is. And that's in the slides, I captured that as adherence, but we use the term exercise relative dose intensity.
Thank you so much.
Thank you. Well, thanks. They're great questions.
Okay.
All right.
Thanks, Jen. Thank you.
Thanks, Lee.
Bye-bye.
Have a safe trip.
Take care.
생각했던 것보다 더 많이 좋아해 주시고 사랑해 주셔서 너무 마음이 기쁩니다.
굉장히 감기가 무량하고
The next speaker is Dr. Lee W. Jones. as a leading researcher in exercise oncology. He has led a wide range of research to investigate the effect of exercise and cancer from bench to bedside or human. He received a master's degree from the Lakehead and completed a doctoral degree and postdoctoral research at the University of Alberta. Currently serving as a professor at the Memorial Sloan Kettering Cancer Center. Dr. Lee Jones has published more than 250 peer-reviewed scientific papers and also over 120 invited international presentations. The topic of today's lecture is a translational approach to the development of exercise as treatment for cancer. Please.
Thank you so much for the nice introduction. It's never hear me okay? Can you hear me? Sorry. Oh, no, that's me. Different mics. All right. That's good enough. Okay. It's an honor and a privilege to be here, to be back in Seoul. This is my third time here. This place is just pretty remarkable. I love it here. It was so nice to see my good friend again. I really appreciate the invitation to meet all the students, which I did yesterday, and everybody else. So it really is a pleasure to be here and have the opportunity to talk about some of our work that we've been doing over the past few years. So without further ado, I will carry on. So I've been in the field of exercise and cancer for about 20 years, believe it or not. So Jessica, who works as part of my program, my research really started looking at the role of exercise to attenuate the physiological side effects of cancer and cancer therapy. And so probably the first half of my career was really focused on that. And Jessica, Dr. Scott spoke about a lot of that research, but I don't do any of that research anymore. Now I focus on a newer side of our program, which is really the impact or association between exercise and cancer development or cancer initiation and progression. I've had to retrain myself. I'm an exercise scientist by training, not a cancer biologist. But I felt that, to take the field forward, I felt like studying the area, the relationship between exercise and cancer pathogenesis is where I needed to be. So I think Memorial Sloan Kettering Cancer Center in the US is a great place to do that kind of research. So that's what I'm going to talk about today. So I think it's important when we think about why exercise in the first place for cancer pathogenesis. Well, I think it's too important to consider what cancer actually is and how cancer development or cancer initiation occurs in the first place. If you think about it, it's really this complex interaction between genetic alterations or epigenetic alterations of cancer cells or epithelial cells, and the interaction of those cells with its microenvironment, the tissue microenvironment in which these cells exist, called the TME, or tumor microenvironment. It's really that interaction. And if you think about it, a lot of cancer therapies over the years are really focused on the cancer cells themselves. Really focused, and really not ignored, if you will, the microenvironment in which these cells live. But of course, with the advent of things like immunotherapy, we know that the tumor microenvironment can be extremely important in determining cancer fate, cancer cell fate, and the risk of development of cancer. So you've really got this interaction between the cells and the microenvironment in which those cells reside. But I think now we're also starting to appreciate that these tissue ecosystems, whether it be in the lung, or the breast, or the liver, or the prostate, of course, don't exist in a vacuum. It exists within a person, a whole body's individual, what we call the systemic milieu, or the host physiology. So I think now what we're trying to understand is it's really the interaction between all of these different factors that determine cancer pathogenesis and probably the risk of all chronic diseases. So if you think about it, it's more that cancer is really an ecosystem. And we know, of course, that things like aging, which is the biggest risk factor for every single type of cancer, can accelerate your risk of cancer. But we also know that the lifestyle behavior is probably the most important determinants of also this interaction. And we know, of course, that what I would describe as genotoxic lifestyle factors, smoking, obesity, accelerate your risk of cancer, likely through the interaction of all these different factors. So within this ecosystem kind of paradigm, we really ask the question, if we know that these unhealthy lifestyle factors can accelerate cancer pathogenesis, can something like exercise, which is really a physiological intervention that has an impact on the entire body, can we then, through exercise-induced changes in the host physiology, does that then in turn have changes and alterations in a tissue microenvironment, and does that then influence the way that cancer cells can maybe develop and progress? So really that was our hypothesis. Can you use something like exercise to treat this entire ecosystem? So that was our hypothesis. So now we're trying to actually test that whether it's actually true or not. So to do that, we developed a framework. I think it's really important when you're thinking about a research question to develop a framework so you have a logical, kind of a rational approach to the question. So I developed this framework about 8 years ago now, and basically my colleagues at Memorial Sloan Kettering are all radiation oncologists, they're medical oncologists, they're surgical oncologists. And so if you think about the development of cancer drugs, they follow a very logical and actually a mandated framework through the FDA getting IND approval. So I thought, well, can we apply such an approach to the development and testing of something like exercise? So nothing like this has ever existed, but I thought, well, why not? Could we do something? So just in brief, what we do here is basically a 6-step process. We start this with discovery epidemiology research. You've heard a lot about that this morning, so I'll briefly touch upon that. But that's not, it doesn't begin and end there. That is just one step. Then you get into, Andy mentioned it a little bit this morning, about molecular epidemiological approaches. Can you now start determining if there's certain subgroups of individuals that may benefit? Of course, with the development of any cancer drug, you would have to do preclinical testing. You have to do mouse work. But that has not really been mandated, of course, in exercise research or any lifestyle research. And in fact, I think it's been something that's been largely ignored, but can be extremely important. Once these discovery steps are being performed, then you can start getting into clinical testing, actually getting into patients and humans, and now starting to test, of course, the safety and feasibility of exercise in some of these populations. We know about the safety and feasibility of exercise in a lot of settings, but of course in oncology, it could be very different given different treatment exposures that individuals might be going through. If these trials work out, then you can get into what I consider to be the signal-seeking trials. This is where you're looking for a biological signal of exercise. This is not exercise to improve fitness or physical function or quality of life. This is a biological signal that you're looking for in the tissue itself. I'll talk about that. If all these steps work, then you can start to consider designing definitive trials, phase 2, phase 3, randomized controlled trials, to look at clinical endpoints in these individuals. So the hope is if we follow this kind of approach, that this really facilitates the rigorous development and testing of exercise in the same manner that you would do for a drug. If you do these things properly, along the way, what we will hopefully prove that exercise does have anti-tumor benefits, just like a drug. You'll able to identify what the right dose of exercise is, because I don't think you can perform these live trials without knowing that. You wouldn't do a drug trial without knowing how much of the dose of drug you needed to give. In drug trials, of course, you also know what we call the predictors of response. You know mostly which individuals might benefit from this drug. You might even have a biomarker of that prediction of response. I think that's what we need also for exercise. And I think also what's going to be important is also to elucidate, find out how exercise actually works. We know a lot about how exercise affects the heart. We know a lot about how exercise affects skeletal muscle, I can tell you we know virtually nothing about how exercise affects the biology of the lung, or the liver, or the prostate. We know virtually nothing, but of course these are all the tissues that are high risk for cancer. So that's what we wanted to achieve. So what I'm going to do over the next half an hour, I'm going to walk you through some of the data we've collected over the past 8 years or so that's trying to apply this framework to development of exercise in cancer. So we heard a lot of talks this morning about the epidemiology evidence we have. And so we just published this came out last week, actually, and luckily it wasn't mentioned this morning, so hopefully this is new information. So this is looking at the relationship between post-diagnosis exercise level and both cancer-specific mortality as well as all-cause mortality. A lot of the studies that Andy talked about this morning looked at either breast cancer, prostate cancer, or colorectal cancer. We felt there was a need to look at all cancers. So we were quite fortunate to come across this data set. This is a nationally based data set in the US, about 11,000 individual cancer survivors with many different types of cancer. And importantly, we have 12 years of follow-up in this particular study, median follow-up actually. And so in this particular cohort, we saw about 4,500 deaths. So we had a lot of power, if you will, to be able to look at the association between exercise and mortality. So we were able to look at cause-specific mortality. So we first looked at cancer mortality. I'll go through this data relatively quickly, but this is all cancer patients combined. This is a pan-cancer analysis. And what you can see, hopefully right away, is that the pink line here, the red line represents individuals reporting not being exercisers, relative to the blue or the teal, which is the exercisers. And there's about a 20% reduction in the hazard for cancer mortality, or the risk of dying from cancer, if you're an exerciser versus a non-exerciser. And this is a multivariate analysis after controlling for BMI, which we'll talk about a little bit, age, cancer treatments, etc. So across the board, about a 20% reduction. And when you look at the individual cancer types, you see more variability. And so this is a forest plot. Anything to the left or to the right of this line means that exercise increases the risk of dying from cancer, that particular cancer. Anything to the left of that line suggests that exercise compared to non-exercise reduces your risk of dying from that form of cancer. Luckily, you see everything to the left of this line, but not everything is significant. Some of the 95% confidence intervals are less than 1, but you do see significant benefits to things like head and neck, to less extent melanoma. So melanoma is one where you see increased risk on the prevention side. Post-diagnosis, you might see decreased risk of dying from melanoma. Prostate was another renal, and others also so suggested evidence, but not suggesting that exercise reduces risk of dying from every single type of cancer. So the data was a little bit more variable. But we also looked then at all-cause mortality. So we, across the board, if you look at all cancer patients, there was about a 25% reduced hazard of all-cause mortality in exercises versus not. If you looked at median survival in individual patients who are non-exercisers after diagnosis, their length of survival was about 15 years. In exercisers, it was 19 years. Now this is observational data, that's not cause and effect. I'm not saying there's a 4-year survival benefit of exercise. Only a randomized controlled trial can do that. But I think it's suggestive. If you look across now individual cancer types, there's a lot more consistency now to the left of the line suggesting exercise as an all-cause mortality benefit for most of the cancers in which we looked at. So this is important, of course, because if you think about a cancer survivor, they're at risk for really of dying of cancer, but also dying at high risk of dying from other things, cardiovascular disease and other causes, which Jessica talked about this morning. If you think about cancer drugs, we're often trying to get the cancer benefit without the toxicity and the risk of individuals that dying from something else. I think exercise, it's almost like a double whammy because it would reduce your risk of dying from cancer, but also your risk of dying from other causes as well. We know that, of course, from all the literature we've had in heart disease, and diabetes, and heart failure. So this is why I think you get this all-cause mortality benefit, because exercise is having both an impact on cancer as well as the risk of dying from other causes, which is really important. Okay, so I mentioned there hasn't been much preclinical evidence. I'm not a basic scientist, I don't pretend to be, but we have done some preclinical studies looking at this, because I think it is important because epidemiologic studies cannot prove cause and effect. It's an association. So if we go to mouse studies, yes, mice on humans, but there we can actually test in a more of a randomized setting, if you will, what the impact of exercise is. So we've done some work in this field, but so have others. So I'll just quickly go through this data. So this is 4 different breast cancer cell lines. You've got the control groups here, you've got exercise, which in this case is voluntary or wheel running. And across the board, you see an exercise that slows the progression of these tumors. It doesn't eradicate these tumors, it slows them down by about 30%. But there's also data now. This is actually data from our group. This is in lung cancer. This is a genetically engineered mouse model of what we call KRAS mutant lung cancer, one of the most aggressive mouse models we have. Exercise was having substantial benefit in slowing these tumors. There's data actually from NYU, a cancer cell paper, which was published a couple of years ago. Also in pancreas cancer. There's data actually in B16 melanoma. This was a cell metabolism paper from Pernille Hodgman's group in Denmark. And this is also data from our group here. This was what we call PDXs. These are patient-derived xenografts. So this is taking a tumor from a patient, putting it in a mouse, randomizing it to exercise or not, and across all these studies, we've shown that exercise slows tumor growth. You know, it was an important point that I kind of mentioned this morning after Ed's talk, when you talk about adiposity. In all of these studies, we don't see these mice losing weight. We don't see them losing weight, and still you get this anti-tumor benefit. Now, we haven't looked at body composition, so maybe there is changes in body composition without changes in weight. That is absolutely possible, but typically we don't really see reductions in weight. So maybe there is explanations beyond just exercise reducing in weight that leads to this anti-cancer benefit. So I think an important question, this is something that Ed mentioned during his talk in terms of cancer prevention. If exercise does work, what is the optimal dose? What's the dose that we should be telling our patients? Because this is what they'll ask you, how much do I need to do? In the US, they'll ask, what's the minimum amount of exercise I need to do to get the benefit? So this is data that isn't published yet. The other thing I should mention, a lot of our data is not published yet. I wanted to give you stuff that's hot off the press, or not even off the press yet. But you can take it with a little bit of a pinch of salt because it's not peer-reviewed yet. So this is a data set we've been working on with our colleagues from France. So this Cantor data set is a national database of about 11,000 women with early-stage breast cancer. So very simply, we've looked at the relationship between post-diagnosis exercise and the risk of recurrence. So not mortality, but recurrence. So we have a lot of data, exercise related to cancer-specific mortality. We actually don't have very much data at all on exercise and recurrence. Only about 5 studies, actually. So we felt there was a gap there that we could look at. So what we wanted to do first, just simply look at the dose response. And so I'll just take you through this data. So here we have, this is the risk of recurrence. So this is 1, anything above this line suggests higher risk of recurrence. Anything below 1 suggests lower risk of recurrence. And this is increasing exercise dose going from 0 all the way up to 75 net hours of exercise a week, which is a lot of exercise. So all I wanted to do is just show me the relationship. What does it look like? I didn't want to say, let's look at exercises versus not, let's just look at it. So what does data look like? So if you go from individuals reporting 0, you can see as individuals report more and more exercise, you get this nice reduction in risk of recurrence. This is a multivariate analysis, by the way. Until you get to about, 30 net hours of exercise a week. After that point, you really get no additional benefit at all. Which is kind of what Ed was talking about this morning. It's not, I wouldn't argue this is a U-shaped relationship. I think it's, I don't know, it's a hockey stick, reverse hockey stick. I lived in Canada, I can't help it. But you certainly get a plateau, you get no additional benefit. So if this was a drug, you would call that the therapeutic window. So doses below that point, you would argue are sub-therapeutic. And the doses above this threshold here are also sub-therapeutic. Exercise is not like taking a pill. it takes a lot of time to exercise. So if you can imagine, if you get the same benefit of doing less versus doing more, then maybe that's the way we could think about it. So that's epidemiologic data, but we've also got preclinical data also looking at this question. So this is PYMT. This is a genetically engineered mouse model of ER-negative breast cancer. These mice spontaneously develop breast cancer. You don't have to inject it. So we looked at 3 different doses: 75, 150 minutes, or 300 minutes of exercise. This was all on treadmill, carefully dosed exercise. We put mice on a treadmill and watched them exercise. I'll just cut to the chase here. 75 minutes really didn't do very much. 150 minutes, it was associated with a significant delay in when these breast cancers were, if you will, when they were detected. 300 minutes was also significant, but it was no better than 150 minutes. In fact, it was actually slightly inferior. So again here, we've got evidence of maybe this middle dose here, 150 minutes, is where you hit the sweet spot, if you will. Doing additional amounts of exercise it's not harmful necessarily, but it doesn't give you additional benefit. And that's twice the amount of exercise. We did another study to look at this. This is the model called 14-1. This is where we inject this right into the mammary fat pad of a mouse with an intact immune system. This time we looked at 4 different exercise doses: 60 minutes a day, an hour a day, 2 hours a day, 3 hours a day, or 4 hours a day, 5 days a week. This study was a monster. So again, and now because these tumors, you can just measure the tumors and how fast they grow. So again, long story short. So this is the control group. You can see without exercise, these tumors grow to about 1 centimeter within about 25 days. They're very fast. But you can see the exercise conditions. These are all the exercise conditions. They're right on top of each other. So what does that tell you? That tells you that in this particular study, in this particular cell line, 60 minutes of exercise a day was just as effective doing 4 hours a day. It was no better. 4 hours was no better than 60 minutes. So again, we don't see this classic dose response. We always think more is better. It seems that maybe that's not the case. So another question that we've had is something that I think is kind of ingrained within exercise research. 1 is more is better. 2 is everybody benefits. Everybody benefits from exercise. So is that true? Is that true for something like cancer? So this is something else we've been very interested in. So we did a study, this was an observational study. I'm not an epidemiologist either, but it was in 6,200 women with early stage breast cancer. We did what everybody else had done up to that point. We simply classified these women into different amounts of exercise that they were reporting and looked at if there was a relationship between exercise and their risk for dying from breast cancer. Now, you don't need to be a statistician to look at these. These are all the different exercise amounts, if you will, but these lines are right over the top of each other. It seemed like higher amounts of exercise was not really associated with a survival benefit in this particular cohort. So what we did then was something that was actually very simple. We thought, well, breast cancer is not one disease. We know that there's ER-positive breast cancer, there's triple-negative breast cancer. So that's what we did. We then stratified this cohort into 3 different clinical subtypes of breast cancer. What we call hormone receptor positive, HER2-negative breast cancer, hormone receptor positive, HER2-positive breast cancer, or what we call triple-negative breast cancer. This is a forest plot, and what you can see here is the benefit of exercise appears to be confined to those women with hormone receptor positive, HER2-negative breast cancer. So now you've got some epidemiologic data, which has its limitations, but suggesting that the impact of exercise on breast cancer mortality actually might differ based on the biology of the tumor. So then we tested that preclinically. So I presented this data before, so we'll see how it goes. Anyway, so what we did, we did this in actually what we call athymic mice. Now this is a limitation of the study, but we did it for a reason. So these are all mice without immune systems. We did that because you need mice without an immune system. If you inject human breast cancer, that's the only time it will grow. If you put a human breast cancer cell line into a mouse that has an immune system, it will reject it. It won't grow. So we did this because the human breast cancer cell lines are very well characterized. in terms of their mutations. So what we did, we took 7 different breast cancer cell lines, so we had 7 different cohorts of mice. All these mice were treated the same. We put 7 different cell lines in each cohort. These are the different cell lines that we had. We then randomized those mice either to control or to exercise training. Now the exercise training in this particular study was all 150 minutes. 5 days a week for 30 minutes at a moderate intensity. So every mouse got treated exactly the same. The control mice also got put on a treadmill, but the treadmill didn't move. So we got the same exposure, same noise, same everything. So everything in these mice is the same except the cell line they got and whether it was exercise versus control. This is the data. So we've got 3 different, very different responses. We had, so the gray represents control, black represents exercise. Essentially, we had 3 cell lines that were sensitive to exercise and tumor growth was slow for exercise versus control. We had 2 cell lines that were completely resistant, if you will, to exercise. So didn't matter if the mouse was exercising or not, tumor growth was exactly the same. And then we had 2 cell lines where tumor growth was faster in exercise versus control. So 3 different phenotypes. I'm not going to present the data, but I then thought, well, maybe it's because the exercise dose is not enough. Justin and I discussed this yesterday. 150 minutes for a mouse, maybe it's not a big deal, maybe it's not too much. So we repeated the experiment and we quadrupled the amount of exercise. Quadrupled. This study took 2 years. It's a lot of training. And I can tell you have to take my word for it, the data is exactly the same. Dose had no impact. We couldn't use a higher dose to convert the non-responders to responders, but the ones that accelerated didn't get even worse. Dose had no impact. What's going on there? Well, what's interesting is all the cell lines that responded all have a mutation in something we call PIK3CA, P10 pathway. This is a metabolism pathway. Very common, about 30% of all breast cancers have mutations in this pathway. So we thought that was kind of interesting. So we've actually got a data set that we're working on the first paper for now, but we've been very fortunate at Memorial Sloan Kettering. They've had a huge effort over the past 8 years, sequencing as many tumors as they possibly can. I think we're up to about 90,000 tumors now, and they've done DNA sequencing of the tumors. We've been very fortunate to get exercise data on about 5,200 of those individuals. So now what we can do is see if the relationship between exercise and survival across multiple different cancer types, if that relationship is different on the basis of different mutation status within these tumors. So 5,200 pan cancer patients, about 900 of those actually are breast cancer. So in our mouse data, we found that this PIK3 mutation, also a mutation in P10, could be mediated, if you will, or maybe moderated, I guess, in response to exercise. So then we looked at that in patients. This is the data. So what we did is we got all the individuals, all the breast cancer patients, and we looked at those who had a mutation in PIK3, the PIK3CA mutation, or they were wild type. Wild type means that there's no alterations. And then we divided them into exercises versus non-exercises, and we looked at survival. So just concentrate on this top figure here. So this is in individuals without a mutation. Green is exercise, yellow is non-exercises. This is survival. There's no difference. You don't need to be a statistician, there's no difference. But look if you're mutant. If you're mutant, you get a survival benefit for exercising, if you're exercising, but only if your tumor has a PIK3 mutation. P10, which is a negative regulator of PI3 kinase, essentially you see the same effect. So you see an interaction, if you will. So maybe this is data here suggesting that, it's maybe even on clinical subtype, maybe the types of mutations that a tumor have will determine whether it responds to exercise or not. So we have some observational data, we've got preclinical data. I'll talk about in a second what we're trying now to do clinically to also look at this. So I think if you look at our framework, today we've I think ticked some boxes, if you will. We've got some discovery epidemiology suggesting a signal. We've got some molecular epi, kind of interesting. I think we've got now some preclinical data also supporting anti-tumor benefit. So now we can get into clinical testing. So I think the first question you would ask, is it even safe and feasible for individuals to exercise in the first place. So I've been very fortunate. I work with Kerry Cournier, is my PhD, so we did some of the very first trials. So over the past, I guess, 20 years, we've probably done now 20 plus randomized trials of exercise in various cancer settings, pre-treatment, during treatment, after treatment, in individuals with metastatic disease across multiple different tumor types. I think we've demonstrated that indeed individuals are very interested in these trials, and we can dose exercise, I think, quite nicely. The problem with all these studies to date is all have been what we call SAT-based. It's involved getting individuals into a center to do exercise. We've only really tested one exercise dose. That exercise dose, quite honestly, has been based on what studies have tested in things like cardiovascular disease. And all have focused typically on things like quality of life, fatigue, fitness. And I think arguably you could say, well, maybe the effects on maybe tumor-related outcomes might be different because there's different pathways that are in effect. So I think there's a lot of unknowns. So if you go back to our framework, do we know what the best dose of exercise is for an anti-tumor benefit of exercise? And do we even have evidence that there's actual a signal for exercise to have an anti-tumor benefit in a person? So I felt that what we needed in this stage to keep the development going is what I think of like phase 1 trial. So think about a phase 1 trial for a drug. Phase 1 trial will be looking at toxicity, maybe does it have anti-tumor efficacy, and I felt that we needed very similar studies for exercise. So that's what we've started to do. And the objective of these trials is to identify what we call the recommended phase 2 dose. So can we find the dose that individuals can do that have an anti-tumor benefit? We then identify that dose, and that's the dose we then move forward into these phase 2 trials because we know that's the dose that people can do and it appears to have benefit. So to do these types of trials, we needed to think differently. So if you think about phase 1 trials, they're typically what we call dose escalation. You might start with the lowest dose and you keep going up and up and up and up. So most exercise trials test 90 minutes or 100 minutes of exercise per week. That wasn't enough, wasn't enough. We need to go higher than that if we're going to find what these doses was. But if you think about a side-paced approach, there's no way I think we could do that. So our side-paced approach essentially involved individuals coming in to Manhattan in New York City. If you've ever been there, you know it's very busy, it's very expensive. So asking all these individuals who don't live in Manhattan to come into our center to exercise with us 5 days a week for an hour at a time for maybe months wasn't going to happen. Just wasn't going to happen. So it's hugely inconvenient, expensive, slow approval, bias. I think it's really limited the kind of studies that we could do. There's no way we could have done a phase 1 trial. So what we did, we developed what we call a decentralized approach or a siteless approach. So we built this platform which we call DPEX, which is a digital platform for exercise. Long story short, what we've been able to do is rather than think about what's the best for us to do trials, what's the best for the patient to do the trial. So we built the entire trial around the patient and being able to do everything remotely in their home. So we can screen individuals using digital tools. I won't get into that, but essentially as soon as an individual becomes eligible, we send them what we call a study kit, which has wearable devices, but also a treadmill, most importantly, with an iPad. So now we can do consent remotely, we can do fitness tests remotely, and every single exercise session is also then delivered remotely with real-time monitoring by our exercise physiologists, some of which live in New York, but others live actually all over the US. We collect a lot of samples in our studies, but we don't ask the individual to go to the center to give samples. We send a company to their house, so it's hugely convenient for the individual. So now, the exercise physiologist is in Manhattan, but the individuals can be anywhere in the tri-state area. So that's the way that we're now thinking about this. So to talk about exercise therapy prescription and administration, so once we send the individual a treadmill, we then do a remotely monitored sub-maximal exercise test. We take them to 85% of their age predicted heart rate max. Actually, before they do this, we actually send them an EKG machine as well to do a rescue EKG for screening to make sure they're safe. And this is all with real-time monitoring by a team of exercise physiologists. Once we have that test, we now know that it's safe for them to exercise, and then we can use that information to personalize the exercise prescription. So basically, Jess kind of mentioned this, but we do what's called a non-linear prescription monitoring method. I'm not going to go into any great detail, but basically all the exercise prescription we do is all based on the treadmill. The frequency, depending on the dose of exercise they get, can be anywhere from 3 to 6 days a week. Intensity across the life of the study could be anywhere from 55 to 100% of their baseline fitness. So this is what we call a periodized non-linear prescription. The duration of each session could be as short as 15 minutes, could be as long as 90 minutes. And the length of the actual exercise prescription can be anywhere from 4 weeks to 18 months, depending on the study. And as I mentioned, we now own a fleet of about 120 treadmills. These are at different depots around the tri-state area, so we ship them to the patient's house. We can now monitor of course, their heart rate, their blood pressure, using their Wi-Fi devices. But then, most importantly, there's real-time monitoring by our exercise physiologist. So as soon as they click on Zoom, the exercise physiologist is there. It's not a discussion about what exercise session they want to do. We know what the prescription is for every single session. So Jess mentioned this, so we know exactly what the planned prescription is for any given session, and then we know exactly what individuals did. So you can now look at the ratio of planned versus completed exercise. The difference in that is what we call the relative dose intensity of exercise, the RDI of exercise. So that's how we measure compliance adherence to the exercise prescription. Okay, so I'm going to talk about really the first study that we used that digital approach to actually perform. And it's this phase 1A dose finding study. And this was in men with localized prostate cancer. So what we did is basically we took individuals, men with early stage prostate cancer, who were scheduled for surgery. So in the US, that could be anywhere from 3 to maybe up 10 weeks between the point of diagnosis to the point of surgery. So what you call that the pre-window opportunity study. So we wanted to take advantage of that setting, because if you think about it, in most circumstances, when we come across an individual who's diagnosed with cancer, either their cancer has been removed, or if they're getting treatment before their cancer, we can't look at just the effect of exercise on the tumor itself, because now it's confounded by the effects of chemotherapy or something else that they might be receiving. So this window is very short, but it allows us to now look at the effect of exercise on the tumor itself without any other therapy being present. So what we did is we took these men and we tested 6 escalated doses of exercise. We started at 90 minutes per week, which is roughly which most of these test, 3 days a week for 30 to 40 minutes. That was our lowest dose. If that then got good adherence, we then went to the next dose. If we got good adherence that, then we went to the next dose, and we kept going. So dose 1 was 90 minutes, dose 2 150, dose 3 was 225, dose 4 was 300 minutes, dose 5 375. That's actually, when we first designed the study, that was the highest dose, but that was not the maximal feasible dose, so we then introduced 450 minutes of exercise. By the way, this is all the men who are inactive, non-exercisers to begin with. So this is the dose escalation we did. We didn't go higher than 450 because I didn't think that was practical, honestly. So we did this dose escalation. So the primary endpoints were basically feasibility, could individuals tolerate and get good compliance to these different doses. And then we also looked at the anti-tumor activity. The way we looked at anti-tumor activity, we looked at reductions in the amount that these cancer cells were proliferating, something called Ki-67. And we also looked at PSA, which is a common biomarker of prostate cancer aggressiveness, if you will. And again, our objective was to identify the lowest feasible dose, so the dose that people could do that had an anti-tumor benefit. So that's what we wanted to do. We wasn't to identify the highest dose, necessarily. We wanted to identify the dose that individuals could do that had an anti-tumor benefit. I'll just quickly mention, this is our range of geographical recruitment. Each dot represents an individual patient. Essentially, now we were recruiting, our recruitment radius for this particular study was about 60 kilometers radius at MSK. So it means we can recruit patients who never would have been eligible for these kind of studies. We can actually go up to about 200 miles now. I'm just going to mention here, just very quickly, there was significant time and cost saving for the patient. So across the life of this study was only about 5 weeks in duration, but we saved on average patients about 2 days across just 5 weeks. If 2 days, if they had to travel in. In terms of cost, if they had to come into the city to do the study, it would have cost them on average about $800. Using our approach, it cost them nothing. It cost them nothing. We don't think about this in trials, but very important. So what about the data? So this is adherence or feasibility. I'll cut a long story short. The adherence across all of these dose levels was excellent. 90 minutes was 98%, 150, 86, 225 was 82, 375, 375 was 87, and 450, 81% compliance rate. Not too bad at all. So what about efficacy? Did exercise have any anti-tumor benefit at all? So this is the delta change. So this is the change in PSA from baseline to post-diagnosis. So what we have here is actually, we looked at what would happen to PSA in men who weren't in this trial. We measured their PSA at baseline and then at the time of surgery. And for all patients, that PSA went up just in a 5-week period. So that was our benchmark. So what does 90 minutes do? Well, I can tell you it doesn't do very much at all. It does nothing to have an impact on PSA level. 150 minutes, really nothing at all either. There's one patient who had a benefit. Maybe they've got a certain mutation, who knows? But then you start to see anti-tumor benefit more consistently when you get to 225 minutes. 300 minutes, not really too bad. 375, again, anti-tumor benefit. 450, also anti-tumor benefit. But I would argue, you get really no additional benefits going beyond 225. So I think this is really important because if we hadn't gone to those higher doses, or we just did the higher doses, not the lower doses, I think we could have concluded maybe 375 is what we need to do. I think my interpretation of our data is, I think that 225 is what, I think that's the lowest dose that is feasible, you get anti-tumor benefit. So that's what we selected as our recommended phase 2 dose. So based upon that, that was just in 5 weeks in the preoperative setting. We then went to the post-operative setting, isolated, not the post, men on active surveillance. These are men who come in, they've got prostate cancer, but they're not treated, because we felt maybe 5 weeks, what's the feasibility of 5 weeks? Very different than maybe over 6 months or 12 months. So we did this study, we took the 225, and now we looked at it over a 6 to 12 month period in men on active surveillance in a very small cohort. This is what you call a dose expansion, and we found the compliance was excellent. So we used that data, and now we're doing a randomized phase 2 trial. 6, again, now at 102 men on active surveillance, randomized either to exercise or control. The primary endpoint here is going to be biological activity, but we're also looking at the rate of clinical progression. If that works, if we get a hit on clinical progression, that will then give us the rationale to then do a randomized controlled trial where the primary endpoint is risk of prostate cancer progression. We're not there yet, we'll see how this goes. It's going pretty well. And then actually just submitted a grant where, this is in prostate cancer, but does this 225 also have efficacy across other solid tumors where we think there might be exercise benefit? Head, neck, lung, breast, colorectal, you name it. So this is what we call an umbrella trial. We now know what the dose is, but now we're going to go to a preoperative treatment of exercise across all these different multiple solid tumors at the same time to see if it has benefits. An exploratory aim in that trial is actually then to do genetic profiling of the tumor baseline to see if we can find genetic predictors of response to exercise. That's the talk for another day. So, and then finally, this is my last slide. I think these kind of studies where we're getting this kind of physiological and digital information combined with tumor or tissue, I think really gives us an opportunity to interrogate how exercise actually works. So in these studies, we're doing pretty extensive physiologic and I would say molecular phenotyping. We get blood, we get stool, so we can sequence and phenotype and do omics on those types of tissues. But of course, in the tumor itself, we also get tumor pre and post, so now we can sequence the tumor, whether it's RNA-seq, whether it's proteomics, We can, you know, whatever it is, single cell, we can do a bunch of different profiling. So the goal is, you know, if we really think of exercise as an ecosystem, we need to understand what is going on in a person's body, and we also need to understand what's going on at the tissue level. And we've started to do this a little bit. I'm going to put up the slide. This is a message slide, right? You can see there's lots of dots and lots of connections. So what I'm showing here is the connection between circulating changes, changes in the stool microbiome, and changes in gene expression of the tissue, of the tumor. Basically, what I'm showing you, the point is everything's connected. But that's physiology. That is physiology. So physiology, biology is connected. So we need to be able to take these systems type approaches to really understand how exercise might affect, in this case, cancer pathogenesis. So with that, I think exercise has promise as an anti-tumor strategy, but I think we need to apply this drug development approach to approach it in a rational and logical fashion. I think this digital approach that we've developed is one approach. I think it helps us now conduct these studies in a manner that previously hasn't really been possible. I think the mechanistic interrogation along the way, I think will help us refine exercise prescription, but also if we know mechanistically how exercise works, can we now start thinking about the rational combination of exercise with different cancer therapy drugs to have additive and synergistic effects. So with that, I'd just like to thank my incredible team at MSK, my good friend again for the invitation, and all of you for listening to me for the past 40 minutes. Thank you so much. Happy to take any questions.
Thank you for your very impressive presentations. Are there any questions and comments on the floor? Please identify your name or institution.
Thank you for very insightful presentation. I really enjoyed it. And I'm a researcher in Seoul National University studying how changing the immune system breast cancer mouse model. I'm wondering, when we are doing a lot of studies, have you ever thought of the data of standard exercise to be an impact on different ways that the exercise therapy should impact?
So for like your exercise protocol starts 3 days after cell injection, and I think 3 days is too short of cancer cells to take the place. So in this case, don't you think it's a pre-exercise model? So I thought it's more like prevention model.
Possibly. I mean, I think I know that a lot of drug studies sometimes wait until the cell line is palpable, and then that's when they give drug. So 3 days, you know, is that enough for the tumor to establish? Maybe, maybe not, but I don't think it's prevention per se. Because I think with prevention, there's no tumor present at all, then you're looking at development. I think our genetically engineered mouse model, the spontaneously developed breast cancer after many, many weeks, I think is more model prevention than. But is 3 days enough? Maybe, maybe not. Could we wait longer? I guess we could. Will we get the same benefits? I don't know. You know, I guess it depends on your perspective a little bit. Because in most circumstances, I think, you know, with the mouse studies, you know, injection of the cell line, waiting for it to grow to a certain size, you know, that's really the model I would argue with maybe advanced disease. Whereas a lot of studies where we're looking at the effects of exercise is really in the adjuvant setting, like earlier stage setting, where more micrometastases you're looking at. These are not good models for that. So I guess we could wait a little bit longer and test again and see. But this is, you know, this is what my basic colleagues recommended that we should do. So, but good question.
Thank you.
Any others?
Thanks, thank you so much. And I love the map from the talk and suggested that. The first question is about the testing, so much testing you got and then the decentralized trial. So did you do like an oxygen consumption test or what? Could you maybe just comment a little bit about on your trial, maybe the summits testing and how you did, and also was there a concern that there's maybe some adverse events? They're doing like 85% at age predicted heart rate max, right?
Yeah.
And did you prepare anything about the potential adverse events?
Yeah. So the question was, we do exercise testing in the patient's home. So is that, is it submax, is it max? Are there safety concerns? Yeah, these are all things that we considered. I'm an exercise physiologist by training, so I've spent my life doing cardiopulmonary exercise tests. So for me to go to submax test, it took a lot out of my home, But I think for these types of studies, even asking individuals to come to our center one time was limiting accrual. So, we really looked at what is the evidence that we have that even submax testing it has safety concerns. And we've done that. We've done thousands in cancer patients, and the adverse event rate very, very low. So I thought we could give it a go. We could give it a go home-based. So we started very slowly. We do a thorough review of EMR to make sure there's no contraindications there. We also do the PAR-Q Plus to make sure there's no other potential reasons that they shouldn't do an exercise test. So we do all the screening we possibly can. Do a baseline EKG, even though that's not great, but it's something. And then we took them to this submax. We've probably done 500 now remotely. We haven't had a single adverse event yet. But we're very careful. Our exercise physiologists are very well trained. So if they do spot something early in the test, they will stop the test. So far, so good. Yeah. So that's we think it's a reasonable strategy. I guess the other way to look at it, we're taking them to 85% of their age predicted heart rate maximum, which I think for most individuals is walking up a flight of stairs, which they do all the time. So we felt that there was a rationale to do it at home. We took it slowly, and so far, yeah.
So you're directly measuring oxygen consumption?
No. Just heart rate. Heart rate to 85%. Yeah, not VO2. No. I was going to say something about VO2 then, but I won't. So, I think for geographic studies, where fitness is the primary endpoint, you have to do oxygen consumption because that's our primary endpoint. For me, it isn't anymore. I'm interested in tumor biology, so the main reason for our testing is one, to get clearance, and two, is to personalize the prescription. After that, our primary endpoint is no longer fitness. So I think in that context, submaximal, I think, is sufficient.
Thank you. My name is Justin from Yonsei University. Another amazing, wonderful, another level talk. That was an excellent talk. So my question actually was regarding the subtype. You talk about P10. Because I used to study about P10 knockout mice.
Beautiful.
And then PI3 kinase and P10 is also all related to insulin signaling.
Yep.
And why do you think that those mutations in the insulin signaling pathway, they seem to have a more benefit from exercising?
Yeah.
Why do you think it is?
Yeah. So the question was about basically we see this. I guess it's not an interaction, but we see the benefit of exercise in individuals who have this mutation in this metabolic signaling pathway, which is AKT, PI3, P10 signaling pathway. It's interesting because I actually thought it would be the opposite. So I don't know if people know, there was a paper, a Nature paper, about 10 years ago now, by Dave Sabatini, a guy called Dave Sabatini, who looked at caloric restriction. And so we looked at the impact of caloric restriction across many different human cancer cell lines. And what he found is those cancer cell lines that are mutated in PIK3 didn't respond to caloric restriction. Didn't respond. And that's a Nature paper, it's a great paper. So this is always in the back of my mind. We might see the same thing, but yet we see the opposite. So why is that? Well, the honest answer, I don't know, but I can speculate. You know, I think, again, I'm not a cancer biologist, but I believe that PIK3 mutated cells, human cells, are even more sensitive to changes in insulin and glucose. This guy used to be at Cornell called Bentley, who discovered PIK3. He's got pretty good data suggesting. So maybe with fluctuations in insulin levels, that maybe you could modulate it by exercise. Maybe these cells are just exquisitely sensitive to those changes.
Or maybe, we know that the cancer is growing with the glucose. So now that with the exercise, you're competing. The cancer cells are competing, and when there's mutation in the insulin signaling, maybe exercise is competing, and then the tumor won't have enough signaling to grow or energy to grow.
Yeah, possibly. Because there's another paper actually, editorial associated with data science. They're talking about who has got cancer cells. The cancer cells always find a way, but maybe you use glucose sufficiently enough that maybe you use glucose for exercise, but it's observational. We actually have a preclinical study on the way right now where we contact inhibited PIK3, and we'll see if the exercise effect is involved. So that will be the true test. We'll see. Tell me about it.
So actually, I'd like to. My name is Sang Lee from nursing school. As long as you said the PI3 kinase and I was quite thrilled. I was quite thrilled with your genetic data. So I believe that this PI3 kinase and the insulin resistance with the PI3 kinase related to systemic inflammation. So actually, when you activated the PI3 kinase with the insulin resistance, all cytokines, especially the interleukin-6 is upregulated. So when you do the mouse, the ex vivo the experiment, did you ever try to look at the microenvironment or surround the tumor, doing fibroblast or immune cells adjacent to tumor, doing like single cell sequencing or something like that?
Yeah, so great question. So yes and no is the answer to that. So I didn't talk about the data today, but some of our very first mouse studies were actually looking at how exercise modulated the tumor microenvironment. Initially more from a hypoxia vascular perspective, actually. This is right in the, I don't want to bore people, but this is right in the era of anti-VEGF therapy, Avastin, and this whole thing about if you prune these inefficient blood vessels, you get improved blood flow in, chemotherapy works better, all of that kind of stuff, which we don't really use very much anymore, I guess, except for certain cancer types. So we wanted to know what is exercise doing to the tumor microenvironment, knowing that exercise is pro-angiogenic, very pro-vascular for the heart and other tissues. And it turns out it's exactly what happens with tumors too. So if you look at solid tumors, which are very hypoxic, as you probably know, if you look in mice that have exercised, the tumors become much more vascularized. And people were like, what are you doing? Now you're increasing blood flow to these tumors. But when you do that, hypoxia decreases, which is, I think, a primary driver of treatment resistance and also, I think, a driver of metastasis. So I think we saw that effect, and then we've done other studies, but some of those other papers I mentioned, also particularly the paper by Kurtz, the cancer cell paper from last year, from NYU, did single cell pancreas and found that you completely change the microenvironment, the cell composition, also the biology, gene expression of those cells. So you definitely changed the entire ecosystem within this tissue microenvironment. There's more T cells present. There's a whole bunch of things going on. So, clearly, the thing, all the different proteins that those elements are, those cells are spitting out are affecting tumor growth. So you've got this huge interaction between that. So it's complex, clearly, but there's much more we need to know. We haven't done single cell yet in our patients yet. And the reason for that is because in this one I just talked about is we were only able to get FFPE tissue. We couldn't get fresh frozen, which you need to do single cell. So we were limited to doing bulk sequencing. But we want to do that. which would be awesome. So great question, thank you so much.
Dr. Jones, do you think what is the main cause or contributor of response heterogeneity? Is there an interest factor, G1 mutation?
Yeah, so the question is what's the predictor of heterogeneity of tumor response to exercise? Is an intrinsic factor? I mean, our data suggests that it might be. I don't think it's going to be. I think it's complex. I think it's maybe naive to say, oh, pick three. But this is what we're doing now, actually, in the prostate cancer samples. We're doing genomic sequencing of the baseline samples to see if we can find a genetic predictor of response. If that turns out to be true, what we'll probably do then is a basket trial. So a basket trial would be, we know what the dose of exercise is, we'll know what mutation within certain tumors responds better to exercise, and so rather than selecting prostate versus breast versus it, we will select on the basis of whether they actually have the mutation or not, and treat based on mutation. So that's kind of where we would like to go, if the data indeed suggests that that's where we should go. So maybe intrinsic factor, a lot of things going on, but that would be quite something if we were able to find.
Thank you for Dr. Richards. Actually, we time's up, and that's the first exam 3. Thank you for everyone who attended. Thank you so much.
근데 내용이 heart rate variability, and how can we use pulmonary fitness as a measure or as a possible tool for cancer benefits. I'm happy to see so many students here. They bring a new level of energy to the program, and so we're very happy to have all of you. I do not really need to introduce our first speaker. You know him so well, Dr. Justin Chun. But just to give you a brief bio on his presentation today. He was trained at Yonsei University, and he also did his master's and doctoral studies at the Department of Kinesiology, Sport and Recreation at the University of Alberta, Canada. Aside to his many numerous publications, he is currently Underwood Distinguished Professor at Yonsei and a co-appointment as faculty at the Cancer Prevention Center of Yonsei Cancer Center here at Science. He's also served on the Paralympics committees for mutual for many years, advising as a consultation as well. His presentation today is Resting Heart Rate. Is it a new health indicator for cancer patients? Please help me welcome Dr. Chun.
준비하면서 한국말 안 배워서 스피킹 이렇게 와주셔서 너무 감사드리고요. 제가 심포지엄을 사실 준비할 여력이 있지는 않았는데 예산도 충분하지 않았는데 저희 모든 대학원생들과 우리 막 교수님들이 같이 으쌰으쌰 준비했어요. 그래서 유튜브 라이브도 사실 저희가 할 수 있는 뭐 이렇게 업체 하면 1,000만 원 든다고 그러더라고요. 근데 우리가 다 배워가지고 하고 사운드 시스템도 이렇게 원래 우리가 프로페셔널하게 했으면 한 100만 원 된다는데 그것도 그냥 안 하고 우리가 하고 학과에 쫄라서 마이크 사달라 그리고 하는 겁니다. 그래서 사실 저희가 한 100% 노력을 막 해서 완벽하게 준비를 하면 더 좋겠지만 그러면 이걸 매년 할 수가 없을 것 같아서 저희가 한 90%의 노력만 그렇지 않으면 막 학생들 막 공부 안 하고 막 이것만 준비하고 있고 막 이래야 될 것 같아서 90% 한 85% 정도 노력만 하다 보니까 행정적인 거라든가 이게 진행에 조금 부족한 부분도 있지만 이렇게 너그럽게 봐주시고 특히 지금은 잠깐 우리 준비하신 분들 일어나신 큰 박수로 한번 우리 Okay, so today I have a many different roles, and then I just realized somebody called me, and my voice, a very private conversation in my room, was aired in YouTube. So those of you who are maybe listening, who I mentioned your name, please forgive me. I didn't have any bad intention. So even my talk today, I know that I have a 20 minutes, but maybe I will cut it short because we have a little bit of delay. So this topic I never presented in any other place. I don't think it has ever presented in any conference, in any session about resting heart rate and cancer. So we're trying something new with myself and Dr. Hyung-il Kim. He's also a GI surgeon, and we'll give you some very interesting finding. But this is not our main area of research. But we thought it was something novel to present to you today. So why and how my resting heart rate story began? It's kind of it's a coincidence. So we all know that cardiopulmonary fitness is important, but how are we going to measure it? So we talked a lot about VO2 max today, right? So this test is an excellent gold standard test, but it costs a lot of money. And then step test, you can do it anywhere. Even without a device, if there's a step, you can do a step test. And we decided to do a step test in our first studies. The reason is because we didn't have a facility to measure VO2 max. So it's not that we love this test. We kind of justify because that's the only test that we can do. Okay, so we did a step test. And we published papers, those, according to the step test, if they are considered as fit, they're more healthy, and then incidence of diabetes or prevalence of diabetes is lower. and then or metabolic syndrome is low. So that's good. We published papers on that. But then we found something very interesting because when I was analyzing those data, when we do step test, the important thing is heart rate recovery. Okay? But then when those tests was developed about 30, 40 years ago, they didn't have a heart rate monitor, but we do. So we could, we could do many analyses. How does it increase? How soon it decrease? Compared to the baseline resting heart rate, how does it increase? How much increase? But we can do many things. And what I found the best is the resting heart rate. So it's almost like, what's the point of even doing the step test? So this is what we found. This is the heart rate recovery data. Obese male unfit versus, like 5.26, 4.80. Resting heart rate 33. The effect of, the resting heart rate was much better indicator of prevalence of metabolic syndrome. So we thought it was kind of odd. So let's look at the bigger data set. So with the type 2 diabetes. So we look at the National Health and Nutritional Examiner Survey, and then we found out that compared to those people whose resting heart rate below 60, and those people whose resting heart rate over 90, it's almost like 2.3 times higher risk of developing diabetes. And then we did that to metabolic syndrome and then also type 2 diabetes. It's about the same. So then let's gather more data. So it wasn't just 1 year, so we collect 3-year data and we looked at it. And then the diabetes, again, the risk of diabetes was 3.85 times higher. And then this is man and woman, and the hypertension was a little bit lower, but the metabolic syndrome is higher. So we thought, that's national representative data set. But then we had another data set, which was from the Korean National Insurance Corporation data. 국민건강보험공단 자료가 있어서 we looked at it and we found very similar, association. Okay, so then we now actually use those were prevalence. But now we actually also kind of find a way to look at the risk or incidence association with incidence. So we look at the undiagnosed diabetes. So in Korea, many people who already have a diabetes, they don't know that they have a diabetes. So we look at the undiagnosed diabetes and then the risk compared to those people below 60. Again, like if it's above 70, 80, 90s, already the risk is doubled and tripled and 4 times higher risk of having undiagnosed diabetes. So resting heart rate is one of the best single measure to predict whether they have diabetes or not, whether it's diagnosed or not diagnosed. And then we actually, with Dong-hoon and then Edward Giovanni, who presented earlier today, we collaborated and then we look at the data. This was professional health follow-up study. Okay, and then we found very similar result. And then Dr. Dong-hoon also did the meta-analysis to confirm the data. So
인슐린이 올라가는 게 무슨 의미냐? 또는 인슐린이 운동을 통해서 떨어지는 게 무슨 의미냐라고 생각하실 수가 있는데 실제로 인슐린과 콜론 캔서에는 깊은 연관성이 있습니다. 그래서 인슐린이 올라갈수록 캔서의 위험이 올라가고 인슐린을 떨어뜨리게 되면 암의 발생과 더 나아가서 암의 재발률을 낮춘다라는 연구가 많이
But that's one of the reasons why actually I delved into cancer research. It's because I knew that if people exercise, the insulin level goes down, insulin resistance goes down in diabetic patients. But what about the cancer? If the insulin goes down, with exercise, does it decrease cancer? That's the reason why I started an exercise study for cancer patients. So we know that these are linked, and we know that diabetes also linked to cancer. So we know that resting heart rate is related to the insulin, metabolic syndrome, but maybe also related to cancer. So how about that? So when Dong-hoon was, Dr. Dong-hoon Lee was in Harvard PhD student, I was visiting, and we shared this idea. What about, let's look at this. Like, what about we look at the relationship between resting heart rate and breast cancer patient, and those people with a higher resting heart rate, they have a higher, systolic blood pressure and TG and glucose is higher. Higher the glucose, higher the risk of developing cancer. So we look at the, actually, with the cancer cohort, with the Sehyo part from the breast cancer department and Singil Kim from the breast cancer, we look at those people with a higher resting heart rate if they have a higher risk of developing cancer recurrence, or maybe increase the cancer mortality. And that's exactly what we found. Those people with a higher resting heart rate, they have higher risk of developing cancer recurrence. What about colorectal cancer? So when I share this idea with the intestinal cancer unit here, anyway, and then they did a interesting study. They look at the polyps and they look at the adenocarcinoma recurrence after 5 years. And those people with a higher resting heart rate, they actually have a higher risk of developing advanced adenoma. This is even after 5 years. And then this is either we divided it to first and second quartile, or with a 70, we see a nice, divergence there. If the people have a higher risk, a higher resting heart rate, they have a higher risk of developing advanced adenoma. And interestingly, this was picked up by media from US. I didn't realize that. And then Edward Giovannici gave a comment, and he's saying that heart rate might be a predictor of recurrent adenomas, which may be an indicator of colorectal cancer risk. And insulin resistance is critical for diabetes and cardiovascular disease. There's a risk, and maybe resting pulse is also predictive of this, because heart rate is a good marker of many things related to health. So okay, so let's look at the actual people with colorectal cancer. We found the cohort at the Severance, and then we analyzed the data. So compared to those people with a low risk heart rate, people with the highest heart rate, is quintile, they have, like, after of just everything, 3.51 times higher risk of all-cause mortality, and cancer-specific mortality also increased by 3 times. And I look at the effect of having a diabetes, like association between diabetes and cancer-specific mortality or all-cause mortality. Hazard ratio is usually about 1.5 and 1.7, and when we look at the data, it's 3 times higher risk. This is one of the single best predictor of their cancer prognosis. So anyway, we also look at the every 10 increment of heart rate, and we found very similar result. So this is what I did when I was at the UK. I was there for about a year, and they have a beautiful data set of about almost 500,000 people, which is called UK Biobank. So we look at the same thing. Those people with a higher resting heart rate, here cancer-specific mortality, or double the risk of cancer-specific mortality with almost 500,000 cohort. So again, the resting heart rate really rocks. I think we really give us a lot of information. So, and then there's actually other, recently about 2023, cervical cancer. Thankfully, they cited about 3 or 4 of our paper. So, which I was happy. And then also another paper saying the resting heart rate is independent predictor of death in patients with colorectal, pancreas, non-cancer cell, lung cancer. But then their sample size is like 200 and 300. So still, this is a growing field, but then a lot of people are interested in about the resting heart rate. So why elevated resting heart rate is associated with the risk of mortality? So if you look at this diagram, I kind of made this diagram when I was in UK, when I had a lot of time. So resting heart rate is not just the cardiopulmonary fitness. We say from the exercise person, if you are fitter, your resting heart rate will be lower. But then also you reflect sympathetic, parasympathetic tone. If you're stressed, your resting heart rate goes up. If you mess up your sleep, the resting heart rate goes up. If you take caffeine, resting heart rate goes up. But this is a very transient, increase and go down. And diet, of course. If you eat a lot of hot food, your resting heart rate goes up. If you eat, your resting heart rate goes up because you have to digest. It's exercise for your intestine. And then when you're fat, resting heart rate goes up. When you smoke, resting heart rate goes up. So this is all risk factors for cancer, right? It's not just the cardiopulmonary fitness, but then if you mess up your sleep, if you don't sleep,
if you increase your body adiposity, if you look, all this is also all related to the prognosis of cancer. But now I don't have time to go into all those, but I'm just going to talk about cardiopulmonary fitness. Is resting heart rate really reflecting cardiopulmonary fitness? We say it is, but there was lack of evidence on that. So what I did when I was in UK, there's a cohort of about 10,000 people. So we look at the VO2 max and the resting heart rate. We just look at the correlation. So compared to those people with a 60, their VO2 max was a 39, and those people whose resting heart rate over 80 is a 30. So right there, we see about 30% reduction. If the resting heart rate is high, they are most likely unfit. Okay. And then we look at this many different ways. But this is anyway. And this was kind of interesting. This is what they did after I left the UK. It's during the COVID when people are not exercising, their VO2 max level goes down, but then resting heart rate does it go up? And it goes up. So it was a really large population data sample. If the whole population's resting heart rate goes up, they are going to be unhealthy. So really, I think, I didn't put the slide in here. I think the resting heart rate is a better indicator of health than just BMI, and then many of the things that we think is important. And resting heart rate data is everywhere. If you dig into your hospital data, you will find it. But how does resting heart rate respond during the chemotherapy? It's going to increase, but no one knows. Nobody reported it. So maybe I'm not aware of it, but then there's not extensive data set during the chemotherapy, does it increase? Maybe about during the cardiotoxicity, or many of the toxicity from the cancer treatment. Is it going to increase the resting heart rate? I think it will. But increase in resting heart rate is a bad thing during the cancer treatment? I don't know. We don't know. Maybe it's a good thing. Maybe it's the proof that the cancer treatment is working. So this is a whole unexplored area that we all have the resting heart rate data, but we are not doing anything at the hospital. It's a vital sign, but we're not doing much with it. So that's something that I think is important for us to dig into that. So we actually have another cohort. I was talking to a cardiology department, and they have a ton of resting heart rate data. And then they have a ton of VO2 max data. So we also looked at it. So here is about 15,000 people, the VO2 max data, here, and then the resting heart, as the resting heart rate goes up, VO2 max go down, but not as much because this is already people who have very low VO2 max. But then person predicted peak VO2, how much they reach, very low as the resting heart rate goes up. They're not as fit as compared to those people who have a lower resting heart rate. But then what we did, I think it's the first time in the world, I believe, but again, I might be wrong. We look at the all-cause mortality, head-to-head compared. Resting heart rate, we know, I told you that is a good indicator of all-cause mortality and cardiovascular mortality, and we know the VO2 max is too. So we look at the quartile here, this is kind of random, but then we see compared to the highest quartile, the lowest quartile of VO2 peak, they actually have about 7.5 times increase risk of mortality, but then resting heart rate is about 3.38 times. So we lost to a VO2 max. Okay, but again, we did a lot of other analysis. But we look at this. This is an AUC curve. This is the first one unadjusted. But then when we adjust sex, age, smoking, drinking, total cholesterol, and medication adjusted, they're about the same. But then resting heart rate, what does it take for us to measure it? All you need is your finger and a watch. So I think resting heart rate has so much potential to be used as a health indicator, not only for cancer, but in general, many of the health conditions. So I think I'm running out of time. So is resting heart rate a risk factor or risk indicator? And this is one very interesting study. There's a beautiful trial and then SHIFT trial. What this trial is doing is they decrease the resting heart rate of a cardiac patient to see if they do better. And make the long story short, they do better, but only those people with a severe heart condition, or if their resting heart rate is over 70. But it would make perfect sense. If your resting heart rate is already 55,
don't try to make it, go lower. But if it's over 70 or 80, watch out. Maybe it's not just a cardiopulmonary fitness. Maybe it's your stress level. Maybe it's your boss. Maybe 지도교수 problem with the professor. So anyway, so look at your lifestyle and then see what is causing the high resting heart rate, and if there is, work on it to bring it down. But anyway, so make the long story short, yes, is lowering the resting heart rate itself is very good. And then again, this is data from the Mendelian randomization. So genetic plays a role. Maybe there's some genetic, so those people who have a low resting heart rate genetically, maybe they will do better. But again, there's always gene and the environment interaction. So there's something that we need to work on more. But I think this is something that I'm just presenting to you and then throwing this idea to you. So go back to your institution and look at the resting heart rate and then see how they are related. So in summary, resting heart rate is a good health indicator. Could be used for prognostic factors for cancer patient. It's a good indicator of cardiopulmonary fitness. Whether high resting heart rate is a risk factor or risk indicator is not clear. So resting heart rate could be regularly monitored in lifestyle modification program to elicit health benefit. I think this is the key as a health professional here. So when we ask people to exercise and change their lifestyle, how are we going to know whether it's working or not? So they actually have to go to the hospital, draw the blood, or go to the VO2 It's all very trouble. It's a lot of time and a lot of money. But then resting heart rate, you can monitor every day at home. So if you change your lifestyle, check your resting heart rate to see if it changes with your change of lifestyle. Thank you.
Thank you, John. Thank you, Dr. John, for that very interesting talk. Using evidence from the UK and Korea, he talked about the evidence on reducing cancer-specific mortality using resting heart rate, and also talked about the potential as a powerful tool for clinical practice. Our next speaker follows exactly in line, so he will talk to us about gastric cancer and using resting heart rate as a prognosis indicator. Dr. Hyung-il Kim graduated from Yonsei University College of Medicine, and he did his internship and training fellowship at Zephyrus Hospital. He's an active member of the Korean Surgical Society, in addition to several professional organizations, including the Korean Gastric Cancer Organization and Korean Cancer Association. His most recent research is about multi-center retrospective study of reduced port robotic gastrectomy, so he has a lot of experience looking at retrospective data. Please help me welcome Dr. Hyung-il Kim.
Nice introduction. I'm Hyung-il Kim from Yonsei University, Department of Surgery. Actually, I'd like to thank Dr. Dong-hoon Lee and Professor Justin Jung for not only for having me today, but also for showing me a new world of cancer exercise treatment in patient care. Actually, we are conducting a prospective clinical trial checking the impact of the exercise on the post-operative recovery on gastric cancer patients. But the topic today is not that prospective clinical trial. That is retrospective analysis of my personal patient history, and I'm going to show it. So actually the Korean patient is very unique because they spend much money and time on some kind of herbal medicine which is supposed to be good for their health, but they rarely work out in the gym. So I always try to make them walk or do kind of exercise, but very reluctant to do that. So I need some kind of evidence, but have nothing before. But now, in collaboration with Professor John, I think we are paving a way to exercise therapy, perioperative exercise therapy for the patient. So I would like to begin with the resting heart rate and mortality in general patient group. So as you know, this disease and longevity and risk of cardiovascular disease and type 2 diabetes mellitus, cardiovascular disease again, and the diabetes, hypertension, and metabolic syndrome is associated with the lasting heart rate. Also, in cancer patient, it's associated with the prognosis in breast cancer and colorectal and pancreatic and non-small cell lung cancer and unselected cancer patient. But there's no report on the gastric cancer patient. So we conducted whether there's a relationship exists between the resting heart rate and prognosis of the gastric cancer patient. So this is a retrospective analysis of my patient history of 1,500 gastric cancer patients underwent gastrectomy in the hospital. The resting heart rate was measured after surgery, and medical and treatment and lifestyle information was collected, and Cox regressional model was developed. So this is the summary of the result. Median follow-up of the 4 years, and there was 174 total deaths and 90 major complications, and about 200 of recurrence, and 1 gastric cancer specific death was reported. We checked the multivariable adjusted model on these 4 major parameters. So one is all-cause mortality, and the second is major complication within 30 days, and recurrence and gastric cancer specific mortality. You can see that these 3 parameters, the resting heart rate was significantly different, except for this, so it's not statistically significant. And we checked the compounding parameters, kind of the demographic, lifestyle, and cancer stage. So this is the detailed analysis of the data. We divided the patient into 4 patient groups, which have a very high heart rate in the quartile 4 and lower heart rate in quartile 1. And there was no difference in age and BMI, but you can see in 4th quartile group, they stayed longer in the hospital, more male, and more current and past smoking history. There was no difference in alcohol and family history or hypertension. And there was more advanced case because more patients underwent adjuvant chemotherapy, more radiation or neoadjuvant therapy, more stage 3 patients in the quartile 4. The more advanced, so the more open surgery was performed in this group, and more total gastrectomy means that more large, more advanced cases underwent total gastrectomy. So this, you can see, so many parameters associated with high heart rate. So we needed to check the compounded parameter. So you can see the beautiful survival curve of the overall survival and gastric cancer specific survival and recurrence. Just the quartile group shows the distinct survival. So we needed to check all these compounded parameters still. Despite all these compounded parameters still, this is can be an independent risk factor for the survival. So we checked the all 4 parameters of all-cause mortality, major complication, recurrence, and gastric cancer specific mortality for these 4 quartile specific group. And you can see the p-value. All these quartile subgroup was significantly different in survival, except these 2. So model 1 stands for the adjustment for the age and sex, and model 2 stands for the adjustment for all the variables affecting the survival. So only except for the gastric cancer specific mortality, all these parameters was significantly different in according to the resting heart rate. And also we checked any of these specific parameters have any influence on the significance. regardless of the age, regardless of the sex, regardless of the BMI and alcohol history, or smoking, or hypertension, or stage. So all these four major category was significant regardless of these parameters. So my talk today concludes an elevated post-operative resting heart rate was associated with an increased risk of the all-cause mortality, major complication, and recurrence. So resting heart rate could be potentially be used to predict the prognosis of patients with gastric cancer. Thank you for your interest.
Thank you, Dr. Kim, for that very informative talk. It's exploratory data, but it has evidence. And we all know that gastric cancer is the number 3 cancer in Korea, so it's a very important topic. I would like to invite the two speakers up here, and we're getting ready for the panel and also, but it's time for questions. If you have questions or comments, please don't be shy. Raise your hand. 네, 저 마이크를 좀 해주실 수 있을까요? 선생님.
Thank you for your excellent presentations. I want to ask just one question. In the clinical settings, we call if any patients have a heart rate under 50 beats per minute, we call the person's bradycardia, right? And then another case is if any patients have over 100 beats per minute heart rate, we call a person's tachycardia, right? What about think about that? I'm saying about that. 일단 교수님들께서 이제 말씀하시는 심박수의 범위들이 이제 정상치 범위 내에서만 이렇게 왔다 갔다 하는 것 같아요. 그 레인지가 60몇에서 80몇 또는 90몇 이렇게 보여지는데 대부분 다 교수님들께서 아시겠지만 50 이하는 저희가 이제 서맥이라고 부르고 100 이상의 심박수는 우리가 이제 빈맥이라고 부르잖아요. 그런 범위하고 관련됐을 때 과연 우리는 이걸 어떻게 지금 교수님들께서 말씀하신 레스팅 하트레이트가 낮아질수록 캔서에 걸릴 확률이 낮고 이 레스팅 하트레이트가 높아질수록 캔서에 걸릴 확률이 높다고 저는 이해를 했거든요. 그래서 이 관계를 어떻게 저희는 이해를 해야 될지.
일단은 그 심장에 문제가 있거나 그런 사람들은 다 제외를 했습니다. 저희들 메디컬 히스토리를 보고 뭐 하이퍼텐션 이런 거가 제외되는 건 아니고요. 그냥 심장 문제 때문에 이제 특별하게 어떤 조치가나 메디케이션이 들어간 사람들은 거기에서 이제 제외가 되는 것이었기 때문에 그분들은 다 제외하고 이제 연구를 한 거여서 지금 말씀하시는 그런 것들이
그 서브젝트가 다 정상입니다.
네, 일단 제 환자들은 다 위암 환자였고 제가 한 13년 동안 수술했던 사람 전부를 먼저 후양적 연구를 대상으로 했고 거기서 이제 카디올로지 메디케이션을 하거나 이제 특별한 문제가 있는 사람들은 다 제외를 하고 연구를 했죠. 그건 어쩔 수가 없습니다. 왜냐면 이제 전향적으로 하더라도 그걸 골라내는 건 쉽지는 않은 일이긴 한데요. 일단 후양적으로 최대한 노력은 했습니다.
교수님 하신 질문을 저 똑같이 해줬거든요. 네, 무슨 말이냐면 지금 제가 말씀드린 60에서 90 다 정상 레벨인 거예요. 근데 60 미만이면 우리가 옛날에 소맥으로 오히려 브래디카르디아 그래서 오히려 이상하다고 얘기했었는데 그 사람들이 제일 건강합니다. 그 사람들이 제일 건강하시고 물론 거기에 heart failure 그래서 좀 아예 심장 쪽에서 문제가 있으신 분들은 막 30, 40 되시는 분들은 저희가 연구에서 제외하지만 그런 분들은 극히 드뭅니다. 그러니까 일반적으로 심장에 cardiac problem이 없는 사람 생각했을 때 그래서 제가 I was speaking English very very good. So anyway, 그래서 정상 범위에 있는 사람들인데 저희가 보기에는 야 이걸 정상이라고 해서 괜찮은 거냐? 저는 아니라고 봅니다. 만약에 우리 나는 하트 레이트가 100 미만이니까 나는 심장이 건강합니다. Maybe heart is okay. 심장 그런데 그거는 우리 건강하지 않다는 여러 가지 다른 인디케이터들을 하트 레이트가 반영하고 있다고 보기 때문에 저는 지금 제가 사실 카디올로지스트를 좀 챌린지하고 싶어요. 이거 정상 범위를 더 좁혀야 되겠다. 근데 이거는 제 주제에 넘는 얘기지만 그래서 저는 언젠가 한번 그분들에게 그 정상 레벨에 대한 것을 어떻게 생각하는지 한번 여쭤보고 싶습니다.
혈압도 지금 점점 낮아지는 시대잖아요. 예전에는 120에 80 이하로 우리가 정상적으로 갔다면 지금 115에 70%를 보는 흔해지고 있더라고요. 정상적으로. 교수님 말씀대로라면 심박수도 레인지가 좀 변화가 있을 텐데 근데 대부분 카디오 톡식, 카디오 어떤 문제가 있는 분들 빼고 정상 범위 내에서 우리가 봤다 그러면 이미 암을 갖고 있는 어떤 환자가 이제 유산소 운동을 하면 대부분 하트레이트 이제 떨어지게 되니까 있잖아요. 떨어지게 되잖아요.
아직 연구는
네?
그런 연구는 아직
그러니까 대부분 일반적으로는 운동을 하면 심박수가 떨어집니다. 그리고 저희는 암의 거리를 두고 낮아졌습니다라고 우리가 받아들일 수 있는 거지.
사실 근데 그거는 지금 되게 이게 가정을 하는 거예요. 그런 쪽에 앞으로 연구가 많이 있어야 되지 않을까 그렇게 생각합니다. So the question was, resting heart rate of 100, I mean between 60 to 100, we say it's normal, but maybe it's not normal to have a 90 or 100. Maybe we need to revisit the normal range. But then he was also saying that maybe if we exercise, the resting heart rate goes down. And I was telling him that not in every case, not in every intervention actually exercise decrease the resting heart rate. Maybe if we see the decrease in resting heart rate, maybe they will respond better to the exercise in cancer outcome or any other outcome or disease outcome. But it has not been studied. Maybe go into your data and then now do a subgroup analysis. If those people who have a better response in the resting heart rate after exercise intervention, maybe they will have a better response rate with the exercise.
전 삼성서울병원 임지영입니다. 교수님께 위암 환자 연구 관련해서 좀 여쭙고 싶은데요. 최근에 아산병원에서 위암 환자의 5년 생존율을 예후를 예측하는 데 있어서 영향을 미치는 인자를 파악을 해보니까 체중, 근육량, 지방량, 영양 상태 이런 게 좀 중요하다고 나왔는데 이것보다 요게 더 예후를 예측할 데 더 큰 게 있을지 좀 궁금한데
일단 거기서 이제 이 하트레이트를 넣고 했는데도 그게 빠진 건지 처음부터 안 들어갔는지 아마 처음부터 안 들어갔을 거예요. 네. 그러니까 우리가 어떤 연구에서 의미가 있다고 나왔다고 해서 그게 모든 상황에서 들어맞는 건 아니기 때문에 상황은 아마 더 체크를 해봐야 될 것 같고 레스팅 하트레이트는 아까 보셨다시피 스테이지, 나이 모든 거에 다 연관이 있습니다. 물론 그거를 다 이제 어저스트를 하고도 이게 인디펜던트 리스크라는 보이긴 했지만 우선순위에서는 조금 오르락 내리락 할 수 있겠죠. 그런 걸 다 봤을 때 어떤 게 중요한가에 대한 얘기는 아마 중요할 것 같고 사실 이제 흔히 우리가 아는 성별, 나이, 스테이지 막 그런 것부터 해나가면 사실 영양 상태랑 레스팅 하트레이트는 그 밑일 수도 있습니다. 그래서 이거 하나 가지고 제가 붙잡고 그런 건 아니고요. 수많은 우리가 환자에게 베네핏을 주기 위한 모든 인터벤션 중에 하나가 우리가 하는 거에만 집중되어 있는데요. 저는 여기서 아까 처음에도 말씀드렸듯이 환자의 역할이 굉장히 무리되고 있는데 이 환자에게 치료에 참여해서 네가 당신이 위해 뭘 할 수 있는지 먼저 생각해 보십시오. 라고 이야기를 할 수 있는 근거가 되는 걸 마련하고 그런 솔루션을 주는데 핵심적인 역할을 하는 거죠. 그러니까 뭐 수많은 것들 다 중요한데 레스팅 하트레이트는 당신의 운동 어떤 피트니스의 어떤 아웃컴이자 뭐 인디케이터고 그걸 좋게 만들어 봅시다 우리. 그런 얘기를 하는 건 되게 중요하다고 생각을 해서 아까 이전에 우리가 갖고 있던 거랑 다른 걸 저에게 보여주셔서 감사하다고 제가 말씀드린 거고요. 아마 여기 앉아 계신 분들은 그런 거에 굉장히 좋은 역할을 할 수 있는 분이라고 생각을 하고 다 같이 일해보고 싶습니다.
그러면 나중에 좀 말씀해 주시면 지금 So the question and comment, question and comments were about why or the importance of including heart rate variability as a variable in research, which has probably not been done in the past. And also his last comment was to include his partner, provide an active role for them. It's very easy to monitor.
네, 이완의 이관입니다. 발표 너무 감사 잘 들었습니다. 일단 어쨌든 LP 스터디라서 뭐 잠재적 기전에 대해서는 잘 이해하기는 힘들지만 아무래도 논문을 쓰시거나 조사하시면서 좀 궁금하셨을 거라고 생각이 좀 드는데 예를 들어 지금 위험 데이터도 보니까 캔서 스페시픽 모탈리티에서는 딱히 유의성이 나타나진 않았는데 리커런스에서만 지금 나타나신 유의성이 나타나신 것 같고 혹은 뭐 전용 교수님께서 조사하신 부분에서는 뭐 어쨌든 암 쪽으로 뭔가 잠재적으로 심박수가 올라갔을 때 뭔가 암에 영향을 미치는 것 같은데 이 현상에 대해서 어떻게 우리가 설명을 현재 하고 있는지가 좀 궁금합니다.
아는 것만 말씀드리면 이벤트가 발생 확률이 낮을수록 디텍션하기가 어려운데요. 우리나라는 그러니까 일기가 많아요. 그러니까 위암에 재발로 죽는 분이 너무 적어서 많은 N값에 비해 그 이벤트가 너무 작은 거예요. 그래서 그걸로 돌아가신 분이랑 다른 걸로 돌아가신 분 다 합쳐야 올코스 모탈리티 정도는 돼야 그게 차이가 나는 거죠. 만약에 이제 미국이나 이제 중국처럼 암이 심한 사람이 많으면 위암 재발로 돌아가신 분의 프로포션이 높아지면 디텍션하기가 쉽습니다. 일단 우리나라랑 일본은 얼리 게스 캔서가 너무 많아서 그걸로 돌아가신 분 별로 없어요. 그러니까 그런 것 때문에 갖고 있는 한계는 있습니다. 그래서 아마 다른 나라 다른 세팅에서는 달라질 겁니다. 이제 몸 피지올로지에 대해서는
그리고 또 하나는 리커런스가 먼저 생기고 그다음에 모탈리티가 오잖아요. 그러니까 그리고 요새는 기간도 길어져 가지고 리커런스는 유의하게 보이지만 gastric cancer 스페시픽 모탈리티는 유의하지 않아요. 그럴 수도 있습니다. 근데 피지올로지 쪽으로 사실 제가 지금 시간이 다 말씀 못 드렸는데요. 엑서사이즈하고 캔서, 그러니까 이 레스팅 하트 레이트하고 캔서의 피지올로지컬 엑스플레이네이션에 대해서 거의 없다고 연구가 없다고 보시면 됩니다. 근데 한번 there was one interesting study. breast cancer patient 하트 레이트 낮추는 약이 있잖아요. 베이타 블로커 있었잖아요. 그래서 2010년도에 그래서 JCO paper. Those people who are taking beta blocker have much better prognosis. But then later somebody reported the opposite data. So it was very controversial. But then in animal basic science data, the sympathetic tone increased, the cancer progression increased. So there's a lot of debate or unclear area why resting heart rate is associated with the cancer prognosis. But then resting heart rate is a composite indicator of many things in our life. So it's really difficult to dissect out one by one. But I think, if the field grows, and then I think more research will be conducted and we'll have an answer.
In consideration of time, Dr. Chun, please relay to Dr. Jones later the whole context. But we had 뒤에 교수님 마지막으로.
네, 대장내과 의사로 일하고 있는 강정현이라고 합니다. 이 홀에 아마 외과에서 2명밖에 없는 것 같아요. 해보니까 일단은 발표 너무 잘 들었고요. 우선은 그 연구 디자인하는 쪽에서 그 레스팅 하트 레이트를 측정하셨던 그 기간이 수술 후 5일째 아마 측정한 값을 사용하신 걸로 일단 제가 봤거든요. 에서도 측면에서. 근데 이게 그 저희가 보통 생각하면 수술 전에 프리옵 이벨레이션에서 정도를 하기 때문에 그 전에 보통 이제 특정 걸 많이 써면 좋지 않았을까 이런 생각이 드는데 POD 5일제를 굳이 이제 하신 그 특별한 이유가 있으신지 하고 혹시 이게 수술을 하게 되면 아무래도 환자분들이 회복하는 그 어떤 상태에 따라서 제가 뭐 잘 모르겠지만 하트레이트도 좀 변화가 있을 수 있지 않을까 특정한 시기에 따라서 그래서 혹시 그런 팩터들이 좀 연구 결과에 영향을 이제 줄 수 있지 않을까 그런 생각이 일단 들고요. 두 번째 질문은 코레타 캔서는 사실 해저드 레이쇼가 거의 3.0이 넘을 정도로 상당한 그 유사성이 큰 걸로 일단 이제 나오고 있는데 스토막 캔서 같은 경우는 해저드 레이쇼가 있긴 있는데 뭐 한 1.5 미만이었던 걸로 이제 그 차이가 있는 것처럼 보이는데 그게 전용관 교수님께서 그때 이전 연구하셨던 것처럼 동료가 뭐 이제 코레타 캔서의 리커런스에 영향이 이제 있는 것처럼 뭔가 이 캔서 디벨롭먼트하고 리커하는 데 있어서의 어떤 그런 피지올로지컬 차이가 스토막 캔서와 코레타 캔서가 좀 되기 때문에 이런 레스팅 하트 레이트의 어떤 클리니컬 임팩트도 좀 다르지 않을까라고 그냥 조금 생각을 해봤는데 그 의견에 대해서 어떤 이제 코멘트를 해주실 수 있을 겁니다.
제가 하는 것만 말씀드리면 일단 이벤트가 닿기 때문에 문제가 됩니다. 일단 환자들이 좀 더 진행함이 많은 환자분이었으면 하자드 레이쇼가 확 올라갈 건데 일단은 얼리 게시 캔서가 많다는 게 제일 문제고 수술 전에는 저희 환자들이 금식을 하고 오세요. 왜냐면 내시경을 해서 수술 전에 클리핑을 하거든요. 금식도 하고 바이오프랩도 이전을 했었고 지금은 안 하지만 일단 금식에 장청소까지 해버리니까 이제 막 그 다음에 수술하려고 입원을 했으니까 수술 전날 수술하는 날은 거의 믿을 수가 없다. 그래서 조금 안정된 게 5일제다. 물론 5일이 되면 이게 합병증을 예측하는 게 아니고 합병증이 결과일 수도 있습니다. 그거는 뭐 저희들도 이제 감안을 하고 쓸 수밖에 없으니까 그렇게 이제 썼습니다. 다 확인했고요. 일단 5일제가 제일 그래도 이렇게 프릭션을 강하게 할 수 있었기 때문에 5일을 썼습니다. 말씀하신 내용도 디스커션에 좀 적었고요. 일단 그런 한계는 있는 것 같습니다.
사실 그 논문에 있는 서플리먼터리 데이터에 하루하루 모두 다 수술 전날부터 하루 이틀 3, 4, 5일까지 다 봤습니다. 그리고 교수님 말씀하신 것 중에서 the discrepancy between the size of hazard ratio for colorectal cancer and stomach cancer is huge. There's no clear explanation for why. But then if you think about obesity risk, association with the obesity and the cancer risk, resting heart rate, the colorectal cancer is more influenced by obesity than stomach cancer. So I think it's also a reflection of their adiposity status. But again, another thing is insulin increase resting heart rate. If the insulin increase, actually it increases sympathetic activity and increase the resting heart rate. So it's all related, but I think more research is needed to answer better for those kind of questions. Thank you.
Thank you, Dr. John. Thank you, Dr. Kim. Thank you to the audience. We'd like to wrap up session 4 and prepare for the panel.
저희가 마지막 세션이 있는데요. 그게 옹콜로지 턱인데 그냥 브레이크 없이 바로 팀장이 들어왔으니까요. 여기 테이블 셋업을 해주시면 화장실 못 가신 분들은 잠깐 다녀오시고 바로 옹콜로지 턱을
오신 분이 장윤정 교수님이십니다. 지금 현재 국립암센터에서 그 중앙암생존자 통합치료센터가 계시고요. 암 쪽 관련해서 많은 분들이 계시는 그리고 헬스케어와 관련된 교수님이시고요. 또 한 분 모셨는데요. 또 한 분은 장윤정 교수님, 양은주 교수님 모셨습니다. 양은주 교수님께서는 연세대학교에서 지금 계시고요. 지금 또한 암에 관해서 많아요. 중요한 제가 아는 거 같아요. 당황스럽다. 예전에 제가 사회 바뀌는 것 중에 신전 안 계시고 이것은 굉장히 당황스러워요. 저는 그냥 소개시켜드리고 뭐 하는 줄 알았는데 이거는 그러니까 토론하는 거예요. 내가 뭐더라도 하겠습니다. 그래서 먼저 뭐 시작을 해요. 그 여러 교수님들이 진짜 다양한 세팅에서 지금 암에 대한 연구를 하시고 표를 하시고 하고 계신 분야에서 어떤 역할을 하시며 어떤 쪽으로 하고 계시는지 간단하게 소개해 주시죠.
안녕하십니까. 저는 국립암센터에서 온 장윤정이라고 합니다. 가정의학과 전문이고 보건 정책과 의료정보 쪽으로 전공을 했었습니다. 그리고 암센터에 와서는 이제 처음에 한 10년간은 국감정보센터라는 이제 정보 제공 사이트를 하는 역할을 했었고, 그다음에는 호스피스 쪽 세팅하는 일을 한 다음에 지금은 이제 생존자 사업 밴드 쪽으로 하고 있습니다.
저는 암재활 전문의라고 스스로 설명하는데 암환자를 사랑하는 재활의학과 전문의라고 표현되는 거 가장 좋아합니다. 10몇 년 동안 암환자들의 삶을 몸으로 다시 사는 삶에 대해서 고민하고 있고 몇 년 전부터 같이 와서 이렇게 많은 분들이 있는 자리에 함께 하셔서 감사합니다.
네, 저는 이제 위암 수술을 하고 있고 한약을 환자들이 너무 좋아해서 저는 그 약을 못 먹게 하고 딴 걸 주려고 했는데 운동을 좀 하려고 했었고요. 이뮨이랑 뉴트리션 중요하다고 생각하는데 운동이 그거를 이제 우리가 인터벤션하기 좋은 대상이라고 생각을 하고 그거를 하는 데 있어서 제가 사실 그런 백그라운드가 없는데 같이 일하게 되면서 여기까지 오게 됐고 앞으로도 계속 활동할 것 같습니다. 그래서 너무 감사하고 이 최대 교수님들도 그렇지만 여기 우리 학생분들도 저를 많이 운동을 시켰고 대단하다고 생각을 하고 있습니다. 그래서 많이 앞으로도 배우려고 하고 좋은 연구를 같이 할 수 있으면 좋겠다 생각하고 있습니다.
이걸로 쓰겠습니다. 사실 여기 소개를 안 했어요. 이세용 교수고요. 이세용 교수님은 체육기능학과에서 스포츠 상해 쪽으로 하시는데 IOC 스포츠 인조리 센터 거기에 우리 한국의 공인도 교수님과 같이 책임자로 해서 많은 연구들을 진행 중에 있고 전 세계적인 리더십을 가지고 있는 분들이 좀 함께 제가 제 옆에 옆방인데 꼬셔가지고 아까 이해동 교수님 옆방, 이세용 교수님 옆에 옆방 대화를 이렇게 모셨는데 흔쾌히 해주셔서 너무 감사드리고 저는 운동과 암을 연구한 지는 한 3년 정도 됐고요. 그 전에는 원래 비만 당뇨를 연구하는 사람인데 비만하면 당뇨병이 걸리는 그 메커니즘이 똑같이 비만하니까 암이 걸리더라고요. 운동하면 당뇨가 치료되듯이 암도 치료되지 않을까? 그 메커니즘 연구가 있지 않을까 했는데 없어가지고 그럼 내가 해야겠다 하고 12년 전부터 이런 암 쪽에 운동 관련 암 쪽을 연구를 하고 있습니다.
본격적으로 한번 토론을 시작해 보고 합시다. 제가 한번 제가 궁금한 거 한번. 지금 운동과 암에 대해서 많이 우리가 얘기를 많이 하고 있어요. 세션 중에. 네. 현재 의료 시스템 내에서 운동과 운동으로 암을 치료하는 그런 것들이 어느 위치에 있는지 좀 알고 싶어요. 비단 우리나라뿐만 아니라 외국은 어떠며 우리는 어떤지에서 먼저 알고서는 얘기하는 게 어떨까요? 그래서 한번 여기 계신 분들 다양한 분야에 계신 분들의 경험들이 많이 있으시다고 생각이 되는데 그 부분에 대해서 먼저 좀 말씀을 나누면서
일단은 이제 한국의 의료 시스템에 대해서 간단하게 말씀을 드리겠습니다. 첫 번째로 정부가 의료행위의 가격을 결정하고 정부가 의료행위에 대한 돈을 내줍니다. 여러분의 세금으로. 그러니까 가격도 결정하고 돈도 내주는 사람이 정부라서 정부의 힘이 굉장히 막강하고 정부가 이 행위는 도움이 돼. 근데 중요하니까 싸게 해야 돼. 그러면 엄청 따지는 거예요. 우리 소아과처럼. 이거 전 빼는 거는 알아서 해. 비싸도 괜찮은 거. 그게 첫 번째고, 그래서 에비던스가 없는 행위에 대해서, 아직 증거가 부족한 행위에 대해서 나라에서 어떤 그런 치료 행위로 보면서 돈을 주는 그런 카테고리를 만들거나 하는 게 아직은 약하다고 저는 생각합니다. 그래서 에비던스를 만들고, 그거의 어떤 치료 우리가 하네스팅 한다고 하죠. 그러니까는 딱 정해진 약처럼 우리의 어떤 운동 행위를 그런 걸로 만들어가는 과정이 필요해요. 에비던스도 필요하고 그런 트리트먼트 모달리티로서 어떤 솔리드한 것을 딱 만들어가지 않으면 나라에서 돈을 주지 않고 돈을 주지 않으면 이렇게 번창할 수가 없습니다. 그런 게 제가 임상에서 보는 저희가 보는 특징이 그런 게 있습니다.
입원을 하게 되면은 환자들을 움직이지 못하게 하는 게 기본 병원에서의 속성입니다. 그래서 침대 밖을 벗어나면은 이제 알람이 울리거나 거기서 떨어지면은 이제 낙상주의 이렇게 가는 거죠. 그래서 사실 환자들이 입원해 있으면 근감소량이나 골감소량이 굉장히 심합니다. 일단 치료를 하기 위한 곳에서의 운동이나 활동은 극히 제한되고 있기 때문에 환자가 입원 후에 일상으로 돌아 생활을 하는 데 있어서 많은 제한이 있는데 이런 부분을 이제 치료로 볼 거냐 아니면 일상의 생활로 볼 거냐에서는 관점의 차이가 좀 있다고 생각을 합니다. 저는 이제 다음 주 월요일에도 정밀영양학회라는 데를 가야지 되는데 영양 부분에서도 굉장히 비슷한 유사한 접근들이 있는 거죠. 그래서 삶으로서 우리가 음식을 대하는 것과 치료적 관점에서 어떤 것을 처방하고 특정 성분이나 이런 것을 더 취하는 것이 이게 치료냐 약이냐 이런 것부터 개념적 차이가 굉장히 크기 때문에 저는 이제 생존자 사업을 하는 입장에서는 기본 엑서사이즈보다는 피지컬 액티비티 일상생활의 활동량을 늘리자라는 관점에서 하는 부분하고 이제 저희 재활의학과 선생님처럼 특정 기능을 향상시키기 위한 또 치료적 접근이 분명히 다르다고 생각을 하고요. 하나 이제 좋은 점의 영양 쪽 분야에서 하나는 집중 영양 치료라는 것이 2014년부터 이제 수가가 생겨서 가는데 그거는 영양 불균형이 있는 이제 주관제라든가 그런 경우에 집중 영양 팀이 가서 이제 상담을 하게 되는 부분이 있습니다. 근데 그거는 이제 병원이라는 곳은 영양사가 항상 있는 곳이기 때문인데 그러면 운동처방사나 아니면 재활의학에서 하고 있는 물리치료사 선생님들이 같은 역할을 해줄 것이냐 이제 여기서는 또 접근의 관점, 전문가적 접근의 관점, 인프라 같은 차이는 있겠지만 저희로 입장에서는 항상 웰컴입니다. 그래서 다 같이 좀 도와주셨으면 좋겠는데 이런 전문 영역 간의 이런 부분들이 좀 차이가 있어서 저희가 그 중간에 저희도 운동과 이런 치료적인 관점의 접근에 어떻게 협력을 해야 될지 항상 곤란한 부분이 있는데요. 이렇게 두 분 교수님이 항상 저희를 많이 도와주셔서 오늘 앞으로 좀 논의하면서 해봤으면 좋겠습니다.
정비를 주셔서 사실 철학적으로 언제부터 환자가 이제 병원에서 치료를 받는지를 좀 책을 이렇게 읽다 보니까 19세기 이제 데카르트 이후부터 점점 의학이 발전되고 환자와 질병을 분리하기 시작하면서 이제 치료는 병원에서 하는 것으로 바뀌는 역사적인 그 흐름들이 있더라고요. 그래서 운동이라고 생각하면 운동이 치료고 약일 수 있고 고치는 하나의 중요한 것이 그래서 병원 내에서만 해야 된다는 이런 어떤 고정관념 또는 저희가 항상 생각하는 제도에 대한 불평감들이 그때부터 이제 환자와 질병을 분리시키기 시작하면서부터 시작이 되는 거라는 생각을 요즘에 합니다. 그래서 가장 좋은 운동과 가장 좋은 컴플라이언스는 나의 일상생활의 삶 가운데 움직이는 것들이 다 몸이 좋은 움직임이 될 때가 가장 좋은 운동일 텐데 그것을 암 환자에게 어떻게 적용시키는지에 대한 해결 방법은 19세기부터 차라리 아예 그냥 돌아가서 고민을 같이 해보면 어떨까라는 생각들을 좀 하고 있습니다. 너무 답답해서 정말 좋고 정말 필요한데 뭐 수가에게야 엄정을 할 수 없고 또 여러 가지 지도적으로 전문 영역 생각하면 답답한 거예요. 그래서 차라리 수학 공부를 하면 어떨까?
저희가 사실은 운동 분야에서 어떻게 보면 스스로 exercise is medicine이라고 얘기를 하는 순간 우리는 치료라는 우리나라 안에서는 의료 시스템 안에 우리를 들어가는 그러면 엑서사이즈가 메디슨이 아니냐? 그러면 엑서사이즈가 메디슨이 될 수 있고 지금 우리 리가 그쪽 연구를 아까 제약회사에서 약을 개발하듯이 운동 개발을 하고 있잖아요. 그래서 제 생각에는 앞으로 이게 과학적인 어프로치가 있어야 되지 않을까 싶어요. 치료 개념으로서의 운동은 어떻게 진행되어야 하며 그리고 헬스 프로모션으로서의 운동은 어떻게 해야 하며 사실은 헬스 프로모션을 하다 보니까 디지즈 프리벤션이 사실 나오잖아요. 이 두 가지가 교집합이 있는데 완전히 겹쳐지지 않는 부분이 있거든요. 근데 그러니까 사람마다 의료 시스템에 계신 분이나 의학이나 치육이나 어떻게 보면은 양쪽의 극단에서 계시면서 중간에 교집합적인 것이 아니라 서로가 다른 점을 가지고 얘기를 하다 보니까 조금 그럴 때는 의견차가 생길 수도 있는 것 같아요. 근데 현재로서 우리가 의료 시스템 안에 들어가야 된다고 생각하면 지금 우리가 사고 수가를 발생하고 있는 불법 행위를 하고 있는 거거든요. 우리나라 의료 시스템 안에서는. 그래서 이게 앞으로 좀 우리 정부에서 그리고 전문가들이 목소리를 내서 어떻게 이런 부분들을 해결해야 되는지 저희가 논의해야 되는데 한 가지 여기서 제일 경계해야 될 거는 집단 이기주의가 있는 것 같아요. 제가 말한 집단 이기주의는 어떤 의사와 체육인의 집단 이기주의뿐만이 아니라 어떤 분이 자격증을 하나 만들면 이건 우리 것. 어떤 자격증은 그렇게 하는 순간 오히려 필드를 죽일 수 있거든요. 그래서 그거는 상당히 집단 중심적인 사고고 우리가 환자와 우리나라 국민들을 생각하면 어떻게 하면 국민들이 자기가 필요한 그런 운동 서비스를 건강을 개선할 수 있는 서비스를 의료 시스템 안에서 받을 수도 있고 그냥 헬스 프로모션 시스템에서 받을 수 있고 어떻게 할 수 있는지를 우리가 정부도 노력하고 우리도 자꾸 제안을 해야 되지 않을까 그렇게 생각하고 있습니다.
I'll share this question with you. There are in the United States, for example, exercise different option without service.
You want to tell like my opinion and then
let me share our situation in Korea of the United States.
Is it covered by insurance?
No. From what I gathered, I believe if you talk to exercise people, this is true on oncology, but many other clinical conditions too. They blame the doctors. The doctors don't understand exercise, how to prescribe. Just bear with me. They blame the doctors. They don't feel that it's important. And it's the same in oncology now. They say we have all this evidence. I don't agree with that. I think it's the responsibility of the exercise researchers to generate better data, better evidence. So where we are in the US, I think there's two camps. There's, the ASCO guidelines were just published by people who believe we have enough evidence that every individual diagnosed with cancer should be given an exercise prescription. And then you have the camp that I'm in saying that I don't think we have the evidence to support. And so I don't think it's the oncologist or the doctor's fault at all. I actually think it's ours. We've got to generate better quality evidence. So in the US, I think until we do that, it won't be insurance covered because I don't think we have the critical evidence of the body of work that would convince insurance that it should be covered. I think I'm in the minority in that opinion, but I work at Memorial Sloan Kettering, and when I stand up to talk about exercise, they judge my evidence the same way they judge anything, and I think that's the way it should be. So I know that's a long answer, but I think there's exercise people have one opinion, but we live in the oncology world, so we have to create the same evidence for any other drug. I think it should be the same. That's my opinion.
As just Lee mentioned, I'm going to speak in Korean now. 근데 리는 지금 사실은 거꾸로 얘기를 하는 거예요. 무슨 말이냐면 미국에 지금 두 가지 캠프가 있는데 사실은 에스코에서 이걸 가이드하신 게 나왔고 그것을 주도한 제이필 리가벨이 이 섹션에 작년에 와서 톡을 했잖아요. 거기는 운동 정말 좋다, 운동 다 해야 된다 하는 거를 메디컬 온콜로지스트 입장에서 작년에 얘기했는데 네가 지금 얘기하는 건 너무 같다. 아직 우리 에비던스 필요하다. 오히려 운동의 입장에서 슬로우 다운 해야 된다는 얘기를 하는 게 우리가 충분한 에비던스 없이 자꾸 가이드만 내고 운동하라고 얘기하면 오히려 이게 거꾸로 역변곡을 나중에 만들 수도 있다. 충분한 에비던스 없는 걸 왜 했냐. 근데 이게 지금 똑같이 우리 리가 얘기한 것도 지금 메디컬 퍼스펙티브에서 얘기를 하는 거예요. 헬스 프로모션이라든가 뭐 하면 다 좋을 수도 있어요. 그래서 이게 참 어려운 그런 것 같아요. 근데 어쨌든 지금 우리가 주제로 하는 거는 메디컬 시스템 안에서 운동이 어떻게 하면 제도적으로 처방되어질 수 있고 이게 제공되어질 수 있는가 상당히 난제인 것 같은데 이거에 대한 해결책이 누가 있으신지 저는 아직 잘 모르겠습니다. 이번에 이재명 씨 건강운동관리사 하시면서 어떠신가요?
물어보시네요. 저는 몇 년 전에 부모부가 미국에서 돌아가 있어요. 근데 방금 이 말씀해 주시고 왜 돌아가시냐면 운동을 너무 많이 하셨어요. 근데 면역력이 떨어지고 몸이 떨어지고 그래서 그런 증거들은 굉장히 많이 필요할 거라는 생각이 들어요. 그리고 건강건강관리사 관련해서 아까 말씀하셨는데 우리는 좀 더 길이 멀지는 않아야 되는 거예요. 왜냐하면 일반 정형외과적인 것들도 제가 또 운동이 치료로 사용되지 않아요. 심폐 쪽이 좀 이제 몸을 적용하고 시작하고 있는데 정형외과적인 것들은 전혀 적용이 안 받고 있는 이 현재 이 상황에서 다음으로 넘어가는 친구들은 정말 많이 필요해요. 그리고 또 문제는 체육계에서 공부한 사람들이 의료종사자로서 인정을 받아줘요. 그만큼의 지식 전달이 전문화되게 전달도 안 될 뿐만 아니라 전문성이 좀 떨어질 수도 있고 운동은 할 줄 아는데 아쉽게도 의학적인 지식 같이 갖고 가면서 가져야 되는 그런 것도 약간 부족한 면이 없지 않아 있는 것 같아요. 그래서 지금 좀 많이 우리가 노력을 해서 정말 좋은 후기를 양성해 나가고 그런 것들을 많이 만들어 나가야 되지 않을까 싶습니다. 그 점들을 같이 하게 만들고 그 운동의 필요성과 이런 것들을 많이 연구하면서 이거를 제시해 주고 하는 것들은 정말 많이 필요할 거라는 생각이 듭니다.
네, 그러면 현재 왜냐하면 검사도 이제 저희 병원에서 어떻게 역할을 하는 게 현실로서 바람직한가? 이 갑자기 의문이 생기고.
안쪽 그대로
말씀을 하고 계시니까 후학들을 위해서.
그게 저는 제 집단 이유를 생각하면요. 저는 개인적으로 말하는데요. 우리가 의료인이 되기 전에 모험 국가를 운동이 측정되는 걸 좋아하지 않는 제 개인적인 이적입니다. 왜냐하면 우리가 안 하는 거예요. 다른 사람이 하는 거예요. 근데 이걸 버리고 접근해야 돼요. 일반인들의 건강을 위해서 우리가 어떻게 할까 생각할 때는 무조건 운동이 의료수가 들어가는 거 같아요. 내가 개인적인 제 치유 쪽에 있는 사람은 정말 그게 배치되는 얘기가 돼요. 그러다 보니까 해결점이 안 나오는 것들이거든요. 그러면 후진들을 위해서 우리가 어떻게 할 것이냐 모르겠어요. 정말 많이.
그러면 저는 어떤 생각을 갖고 지금 제자들을 보는사를 따라고 얘기를 하냐면요. 제 뜻 때문에 오히려 물리치료과 다니는 학생들이 저희 쪽에 대학원에 와서 석사, 박사를 마치고 이렇게 자격증을 취득한 다음에 오히려 병원에서 나오려고 해요. 근데 오히려 우리는 굳이 왜 병원으로 이렇게, 저도 병원 베이스에서 있었지만 들어가려고 하는지, 이게 지금 아이러니한 문제 중에 하나일 겁니다. 죄송합니다. 제가 딴 말을 해서.
좋은 의견 좀 많이 참고를 하고 있습니다.
제가 뭐 사실 많이 아는 건 아닌데 제가 우리나라에서 겪은 것에 대한 몇 가지 생각만 말씀드리면 운동이 만약에 싸고 좋은 치료로 방향을 잡으면 그거는 안 돼요. 싸고 좋은 치료는 우리나라에서 성공한 적이 한 번도 없어요. 왜냐하면 프라핏이 안 남거든요. 프라핏이 안 나오면 병원에서 그거를 했다가는 손댈 때마다 네거티브가 되기 때문에 운동 치료가 만약에 싸고 좋은 방향으로 가면 병원에서는 그거를 스스로 병원도 먹고는 살아야 돼요. 왜냐면 우리가 한 살 위해 노력을 하는 거랑 그 어떤 노력들이 그냥 무료로 공사되거나 더 평가되는 거를 하게 되면 그거는 사실 어느 병원에서 그걸 안 할 거예요. 그러니까 병원에서 써야지 그 약을 써야지 되는 거는 그러니까 운동이 약이면 그 약을 자꾸 처방을 해야지 이게 되는 건데 처방할 때마다 병원이 네거티브가 나면 그 약은 못 쓰게 되는 거죠. 그래서 제가 딴 건 모르겠는데 우리나라의 의료 현장에서 싸고 좋은 건 살아남은 적이 없다. 그러므로 운동도 그 길을 가게 되면 무조건 안 될 겁니다. 네.
요즘에 이제 암 쪽 연구에서 올해 헬스케어 연구를 시작을 했는데 사실 교수님이 과제를 내주셨긴 했지만 운동이나 이제 재활과 관련된 선정되지는 않고 실제로는 다 인물이나 음식, 영양까지는 왔습니다. 다음에 지금 기술 수요 조사도 하고 있는데 어떤 생존자를 위해서 어떤 것이 더 필요할 것인가에 대한 의견을 통과돼 24년도에서는 연도에 형규가 낼때 돼서 형규과제 선정이나 여기 맞춰지지 않는데 그럼에도 불구하고 많은 연구에서 지표로 하나 잡는 게 근감소증 환자의 근육량에 관련된 그 근육량이 생존 과정에 된다는 근육량 부분은 영양과 대사, 이동과 생활 활동과 같이 근데 이런 기준이기 때문에 이런 부분에 관심하는 거는 굉장히 긍정적인 부분이고 그것을 어떻게 그러면 근거를 만들어 가면서 의견에서 환자의 근육량을 늘리는데 그런 부분 하는 부분이 서방적인 부분과 물리적인 하나 있고요. 또 하나는 이제 교수님께서 저희 생존자 사업에 암 환자들 대상에 일상에서 할 수 있는 운동 프로그램들을 제안을 해주시고 교육을 해주시고 저희가 전국 14개 센터에 포되고 있습니다. 임지 박사님이 올해 처음 국립암센터에 사실 스포츠 메디슨 전공자로서 국립암센터의 유일한 박사입니다. 네, 아마 기대도 많고 저희가 지금 굉장히 아쉬운 부분 중에 하나는 저희가 이 프로그램을 14개 센터에 다 교육을 했는데 그러면은 여기 계신 분들은 변호사, 사회복지사 이런 분들이에요. 우리는 운동 몰라요. 이거 어떻게 가르쳐요? 이러시거든요. 그러면 그렇다 그래서 전문가들이 항상 갈 수 있는 게 아니잖아요. 지역에 대학이 있으실 때도 스포츠학들이 전공하시는 교수님들이 계신데 이 암생존자 운동에 관심이 있으신 분은 없을까요? 그런 교수님이 다시 연결이 되면 학생들이 연결이 되고 실습과정처럼 항상 그러니까 이 환자에 대한 개념이 없잖아요. 일반인 정상인 엘리트 체육 하시는 분들이라던가 이런 식의 관심이 있는데 실제 이 엑서사이즈 온콜로지라는 개념을 하려면 도대체 교수님들은 어떤 사람들이 D를 먼저 알아야 돼. 그걸 접할 수 있는 가장 좋은 접점이 이 스포츠 센터의 대학 프로그램이 같이 기억이 되고 이게 한 거는 안 된다 하셨지만은 먼저는 노출이 되고 이게 베이스가 하시고 안 생존자에 대한 이해가 이거는 어떻게 보면 학생 봉사이기도 하고 저희가 볼런티어링이 굉장히 중요하다고 생각하거든요. 처음부터 전문가가 있고 돈을 줄 수는 없습니다. 하지만 인프라가 인식이 확산되는 게 체육인에게서도 확산이 돼야 돼요. 생존자에 대해서도 이렇게 도움을 받으니까 나도 도움이 되네라는 게 센터부터 만들어지면은 지역에 있는 다른 부분에서 될 수가 있거든요. 교수님께 좀 듣고 싶은 거는 이런 엑서사이즈 온콜로지에 대한 관점을 그러니까 저희는 생존자 통합지 센터라는 인프라가 있고 거기서는 굉장히 이게 이제 지역에 전국 14개의 지역에 있는 관심 있으신 대학 교수님들하고 조금 연결이 된다면 그 학교에서 이제 학생들이 나오시거나 해서 암 생존자마다 사실 기본적으로 해야 되는 것도 있지만 무슨 암 환자가 무슨 암 치료를 받았을 때 어떤 부분이 위크니스가 있고 어떤 부분을 또 강화시켜야 되고 하는 교수님 너무 잘하시거든요. 근데 이것들을 일반 체육인들은 관심이 없으십니다. 그리고 암 생존자 암 환자 몰라요. 그냥 박사하세요라는 건데 이렇게 오히려 더 보내지는 경우들도 있거든요. 그거는 아까 너무 빨리 가지 말아야 된다라는 것도 저도 공감을 하고 저희가 그 중간에 브릿지 역할로 해줄 수 있는 부분은 함께 할 수 있는 게 있다라고 생각을 합니다. 그러니까 쉽고 접근하기 필요한 것부터 하면서 진짜 어려운 난제에
좋은 말씀 해주셨는데 사실 우리 장윤정 교수님은 현재 암 생존자 헬스케어 연구 단장을 하시면서 정말 국가적으로 암 환자 헬스케어 연구를 지금 총책임하고 계세요. 그 부분에 설명이 잘 안 된 것 같아요. 이제 교수님 말씀하신 부분 그런 생각이 드네요. 그러니까 이걸 저희는 뭐 자격증자 이런 거를 만들 정말 이게 되게 난제예요. 왜냐하면 지금 여기 오신 교수님들은 정말 대단하신 거예요. 엑서사이즈 온콜로지라는 분야에 대해서 관심을 가지고 오신 분이 계시다라는 거. 그리고 사실 또 우리 의료진 외과 교수님들이 많이 오셨는데 정말 이게 저희가 어떻게 보면 새로운 어떤 분야를 지금 만들어가고 있긴 하거든요. 이게 연구로서의 엑서사이즈 온콜로지와 현장에서의 프랙티스로서의 엑서사이즈 온콜로지는 아직 갭이 큽니다. 그러니까 아까 이런 거예요. 왜냐면 캔서 리커런스가 오는데 그래서 리커런스가 오고 다 돌아가시지 않아요. 하지만 리커런스는 사망 경우는 없잖아요. 그렇듯이 우리가 연구로서 엑서사이즈 온콜로지를 여러분들 지금 의학들이 많이 하시고 새로 많이 만드는 결국에는 뒤에 가서는 이게 정말 중요하구나. 그리고 뭐 쌀 때는 제가 당장 감염자가 아니라 모르겠지만 이것이 수가가 나오는 시기가 생길 텐데 그 부분에서도 아까 이세환 교수님이랑 저랑 같은 생각인데 되게 거기다 안제가 하나 걸려있는 게 자격제도인 거예요. 건강운동관리사도 결국엔 문화체육관광 모든 의료시설 모든 모습이 어떻게 레컨사일이 될 건지 이게 상당히 어려운 부분인데 이 부분을 해결하시려고 우리 양훈주 교수님께서 작년에 과제를 하고 올해도 하고 계시죠. 역사에 양훈주 교수님 향해서 의견을 여쭤보고 싶어요. 갑자기
써서 말하는 것 같아요. 저는 이 두 접근이 정말 다 필요한 에피데미올로지부터 시작해서 엑스트랙션하는 과정, 크게 바라봐서 운동이 약이다라는 접근과 그다음에 퍼스널라이제이션, 그래서 정말 개별화된 옵티마이즈드 엑서사이즈라는 두 가지 접근이 둘 다 필요한데 저희들이 전명 교수님 연구하면서 학생분들이 같이 환자분들과 운동하는 경험의 시간들은 정말 중요하고 그것들이 쌓여서 정말 운동하시는 분들이 암 환자분들과 운동하는 그 경험들이 쌓이면 쌓일수록 그 답을 찾아갈 수 있지 않을까라는 생각을 좀 하는데요. 좀 그래서 말씀하셨기를 그러니까 트리트먼트처럼 엑서사이즈가 되면 에비던스가 내가 좋은 약은 나에게 딱 맞는 약이 되었을 때 때문에 암 환자분들을 저도 10여 년 동안 제가 정말 제대로 기여를 보고 있다라고 생각하는데 요즘에 겨우 10몇 년 지나서 겨우 좀 죄송하지 않은 환자 마음 겨우 들거든요. 그런 것처럼 약간 정말 스페시픽하게 그 환자에게 가장 적절한 운동을 얘기해 줄 수 있으려면 그럼 전문가의 이 약이 정말 비싸게 팔 수 있을 만한 그 노력은 그 모든 걸 생각하면서 작업하지만 그 노력이 깊어질수록 언젠간 인정받지 않을까라는 생각으로 저는 살고 있고 그것들 같은 보내셨습니다.
예. 국립순천대학교에서 노홍석입니다. 여러 가지 내용 감사드리고요. 그 일을 하다 보니까 전남 보건의료 시민위원, 전남 일명관 위원, 또 관광지사업 자문위원, 또 보건복지부 한 사업을 단계를 한 12년 정도를 했어요. 그리고 이제 22개 저희 전남에 22개 시군이거든요. 그래서 보건소기를 많이 들여다봅니다. 근데 이제 운동, 또 영양, 절주, 금연 해가지고 굉장히 중요한 부분인데 운동 전문가가 없어요. 너무 안타깝더라고요. 이제 그런 부분에서 이제 최근에 최근에서 나왔던 내용들이 이제 우리 인증제, 우리 체육 이런 일정한 요건을 갖추면 운동을 실제로 사용할 수 있는 인증제로 이제 그런 얘기가 좀 나왔었거든요. 그래서 아마 그런 내용 부분들은 우리 학생들도 굉장히 관심 있는 부분이라 생각을 해요. 그리고 이제 의료계에 계시는 분들도 실제로 그런 자격이 있어야 같이 일을 갖고 이렇게 하는 부분이 있는데 그래서 인증제적인 그런 측면에서 좀 접근할 필요도 있지 않나 생각을 하고 또 거기에 또 깊이 있게 관여하신 분들 교수님들 얘기 들어보면 그 목적에서도 실제로 이제 체육인의 공통된 의견을 가져가라 이런 게 굉장히 큰 것 같아요. 인증제 부분에 대해서 그런 쪽으로 굉장히 우리가 자격을 갖추고 계속 에비던스를 쌓고 하는 생각이 들고요. 제가 또 한 가지 아까 레스피레이터가 굉장히 메라지 건강식품에 중요한 제어를 얘기를 하고 하셨는데 저도 이제 우연한 게 한 3년 전부터 그런 쪽으로 연구를 하고 지난주 금요일 날 또 공주 센터병원에서 특강도 좀 하고 막 다른 논문도 쓰고 막 하니까 이제 특강도 요청하고 하고 있는데 제가 하고자 하는 얘기는 이제 요즘 거의 반품이라고 할 정도의 그 맨발 걷기, 어싱 또는 접지 이쪽입니다. 그래서 지금 글쎄요 이제 저희가 여러 가지 내용이 있지만 그 사람의 가장 메커니즘을 안정화시키는 부분이 정말로 그 땅으로 돌아가는 것이 아니냐. 그래서 그런 부분에서 접근한다면 레시스트 파트가 굉장히 중요한 어떤 건강 지표이듯이 사람 몸이 맨 땅에 닿으면 그게 암 환자든 당뇨 저도 그쪽으로 연구를 해보고 외국 나온 논문도 하게 되면요 이건 너무나도 우리가 의료인이나 체육인이나 할 것 없이 연구를 많이 해서 에비던스를 쌓아야 되겠다. 이런 생각을 늘 하고 또 저도 그냥 거의 일주일에 3번 이상 많이 이상 그러면 산이든 뭐 이든 맨발로 해요. 근데 거의 방풍이 일어나시다시피 전국적으로 확산되고 있는 상황인데 이런 우리 체육인이나 의료인이나 그런 부분에서 같이 좀 그쪽으로도 정말 많이 연구를 해야 되지 않느냐. 왜냐면요, 사람들이 본인이 느끼기 때문에 저도 많이 느끼거든요. 본인이 좋다는 걸 느끼기 때문에 거기 참여를 하시고 또 그냥 많이 또 확산되고 있는 이런 게 있다. 그런 게 우리가 과학적 증명을 계속 해야 되는 생각이 듭니다. 아무튼 혹시 이 부분에 대해서 혹시 코멘트라든가 좀 의견을 가지고 계신 분이 계시면 말씀 주셔도 좋고 아니면 어쩔 수 없고 그래서 그쪽으로는 많이 들여다보고 연구도 해야 할 필요가 있지 않나 생각합니다. 고맙습니다. 좋은 말씀이시고요. 사실 맨발 걷기 열풍이 지금 불고 있는데 그거에 대해서 저희가 앞으로 과학적 검증이 필요할 거라고 생각합니다. 왜냐하면 사실 모든 연구들이 어떤 경우는 현장에서 시작하고 연구가 쫓아가는 경우도 있고 그때는 연구로 시작해서 현장에 갈 때도 있고 그래서 그 부분은 제가 좀 더 개인적인 의견이 있지만 그런 부분을 일단 말씀드리고 그런 이렇게 지금 필드의 요청이 어떻게 보면 연구를 주도할 수 있는 그런 것들 앞으로 계속 있지 않을까 그 부분 그 정도로 말씀드립니다.
가정 예방이 중요하다고 삼진 예방
양 교수님한테 여쭤보고 싶은데 국립암센터에서 현재 지금 이제 스포츠과학 박사하신 분을 이제 모셨다가 운동 촬영하고 암 환자를 관리하고 있잖아요. 지금
병원으로
연구로만. 그럼 병원 쪽하고 연계해가지고는 앞으로의 어떤 계획이 있으신가요?
일단 저는 이제 소속이 윤지 박사님도 마찬가지지만 국방 사업 공부라는 곳이 있고 거기서 암관리 사업에서 저희는 암 생존자사업 아까 말씀드렸듯이 생존자가 일상으로 돌아가기 위한 인프라를 계신 거고 정 교수님이 이제 저희와 함께 하시면서 그 부분에 전문가를 모셨다 볼 수 있습니다. 병원 쪽의 상황하고는 약간 좀 다르고요. 병원 환자들 대상의 연구는 당연히 같이 진행해야 되는데 올해 왔기 때문에 연구 계획은 내년부터 아마 가능하지 않을까 싶습니다. 때가 큽니다. 네.
우리 사회 봤을 때는 정말 힘들고 재미없었는데 너무 맞습니다. 혹시 이게 학생들이나 뭐 힘들고 질문 있으면 그런 질문 다.
저는 에바이트라는 회사에서 상관이라고
저희 회사가 재활운동 앱을 개발하고 DTX 쪽으로 지금 이제 탐색 임상을 진행하고 있는데 저희는 이제 우선적으로 만성질환 환자분들을 토대로 진행을 하고 있었어요. 이런 이제 암 환자분들도 운동이 중요하다는 걸 알고 이런 심포지엄에 들어오게 되었는데 오늘 들어보니까 이제 암 환자분들 관련해가지고는 연구 기간이 꽤나 길게 잡히더라고요. 승물도 겪게 질환할 때 8주에서 12주 정도 운동을 했고 뭐 오시자마자 이제 만성이다 보니까 그 안에 서브젝트로 들어오신 분들 한해서는 바로 운동을 진행하게 되었는데 암 환자분들 같은 경우에서는 수술에 어느 정도 지나서 비대면으로 운동 프로그램을 전달할 수 있을지 그리고 이제 적정한 운동 기간을 생각하시는 부분이 있을지 교수님들한테 한번 여쭤보고 싶어요.
질문이 오늘 하루 종일 해야 될 것 같아요.
그리고 접근은 크게 저는 두 가지를 봅니다. 그러니까 1기 환자 같은 경우는 재발해서 돌아가시는 분이 없어요. 그런 분들은 빠른 일상으로의 회복을 목표로 하고 있고 빠른 퇴원, 빠른 일상회복, 빠른 직장 복귀가 저희 목표고 3, 4기인 환자 같은 경우는 너무 많이 사망하시니까 생존율을 올리는 게 목표입니다. 그분들한테 미용도 필요 없고 살해줄도 일단은 나중 문제. 왜냐하면 살인도 중요해요. 지금 말씀하신 거가 사실은 첫 번째가 조금 더 맞아요. 그래서 제가 로봇을 같은 경우는 이제 2, 3일 시대 가시는 거고 그런 경우는 이제 빠른 회복과 빠른 일상의 복귀가 그런 경우는 하게 되는 거죠. 그러니까 그런 경우는 사실 저는 옛날에 제가 할 때는 뭐 한 달이고 뭐 두 달이고 쉬었다가 복귀하는 게 목표였지만 지금은 그렇진 않아요. 저는 이제 그걸 높게 잡고 있거든요. 그래서 한 달 이내 대부분의 것을 돌아가게 하는 게 저희 목표고 하고 3, 4주 후에 결과 나올 때 외래에서 보고 그동안 어땠는지 보고 이제 하던 일 하시라고 말씀드리는 게 저희 목표입니다. 그래서 저 개인적으로는 한 달 이내 일상으로의 회복이 1, 2기 환자들한테는 저 개인적으로 그렇습니다.
아주 좋은 말씀 해주셨는데 사실 우리 교수님하고 저하고 여기 대장암센터, 이방암센터, 대장암센터를 같이 일하면서 이제는 수술한 다음 날부터 운동시키고요. 그 기간은 그때마다 운동시키는 목적이 달라집니다. 운동시키는 목적이 달라질 때마다 운동 프로그램이 또 달라집니다. 그걸 몇 주 해야 되냐, 어떤 운동을 해야 되냐라고 하는 부분을 답변을 받기 어렵지만 우리 개인 퍼스널라이제이션 얘기했지만 환자의 상태와 운동의 목적에 따라 참여 운동과 기간과 시작 시점
나는 뭐 질문이 있으실 것 같지만 마지막 마음에 들어야 될 것 같습니다. 나와주시는
저희 광고 하나 하겠는데요. 저희 사진을 다 같이 찍으면 좋을 것 같습니다. 근데 제 생각에 여기 다 나와서 찍은 사진이 안 나올 것 같고요. 사진 찍을 사람 우리 빨리 나와서 거기 사진을 찍고 우리 같은 가운데로 모여 앉으면 어떨까요? 뒤에 계신 분들도 조금 이렇게 앉으면 참 좋을 것 같습니다.
그냥 찍어도 내가
그리고 연장적으로 나머지 한번 연장 한 번도 가지 마시고